Pekný deň prajem.
Good morning. If I may ask you, I can still see Dushan standing in the back. I would like to, ladies and gentlemen, welcome you to today's conference, which is called Health Data Value. We kept the title in English because it sounds better than in Slovak. Today is specific, or today's conference is specific by being a culmination of many years of work of analysts, lawyers, IT people, people from National Center of Health Information, from the American Chamber, insurance companies, legal companies across the entire center. More than half a year, we were discussing data, where we take them, what are the strengths and weaknesses, what processes could be improved, what IT solutions are available. And today is a day where we would like to present the conclusions of all these findings. And what is key in these 2.5 years of cooperation is the main point, and that is that all key partners and key stakeholders are at a single table, and we are discussing where to move the data to obtain the added value. Why we need data, I don't have to explain. All of you in this room know that it's the basis of any modern health policy. During COVID, we all could observe it, that the countries that have real time and quality data available had better results in prevalence and mortality, which I presume the foreign speakers will today mention. Before I start, before we start with the initial program, I didn't introduce myself. My name is Martin Smatana. I will be your today's moderator because I more moderate than debate. I probably better ask questions than answer them. It's very official meeting because we have the minister, state secretary, high representatives from the Czech Republic across the entire sector. I would, however, be very glad if it was an informal meeting. Don't hesitate to ask questions because all the project is about cooperation. There is some communication to improve the situation. Since we are a nation who cannot ask questions and doesn't like to ask questions, we have Slido available. It will be on the screen for you. If you don't have to ask live, you can use Slido. Slido, I don't know if you know it, but it's a Slovak product because we are so hesitant to ask questions that we had to create an application to do so. Before we start with the program, we have a program that should be finished by 2 p.m. We have a larger break about 11 o'clock, where there should be Bratislava Declaration signed in the next room, which you had available. Probably we didn't come up with a better name that Bratislava declaration, so we are just IT people, so we apologize for lack of imagination, but it's a milestone which we consider for the future in the data policy. If I can, if I may now, I would like to welcome Mr. Gabriel Gabozzi, who is the President of American Chamber and the Chairman of Slovak AI and Country General Manager of AT&T, who will introduce the formal agenda, and thereby we will officially start this conference. Gabriel, the floor is yours. Thank you very much. Dear Minister, State Secretary, ladies and gentlemen, and precious guests, it's my honor to open this conference on behalf of the American Chamber. As Martin mentioned initially, American Chamber associates more than 300 members across 26 countries. Looking at these more than 300 members, they employ more than 110,000 employees in the Slovak Republic. Multiply this with their families and children, we are talking about a large number of people influenced or represented by the American Chamber. We are happy that is an initiator of the discussions like this or projects like this. Maybe a question, why the American Chamber and why employers organization is dealing with data in healthcare or healthcare as such. It's my conviction that a healthy employee, a employee who knows about their status, can take care of their families, has better performance and can create more added value. So the link between healthcare and employers is justified. Martin mentioned that today's conference is named Health Data Value. We believe that data should be the thing that objectively show the naked truth, so to speak, and show how the system works and where it should go. And high quality good data, which is the basis for any decision making, or should be the basis for any good decision making, is the important point. Martin mentioned that this is a culmination of 2.5 years of efforts or initiatives that the AmCham, together with other partners, was dealing with. Today, when with the minister and others we were sitting at the round table, I joked that I consider it this is a beginning, not culmination. So I believe that the 2.5 years that colleagues worked on is a point zero in which we say, yes, we have data, we know what systems we have, we know where we have things that in a way are issues where we need to work on, and we know where to get to. I would like to thank all of you who came, all the partners who took part, and wish you a pleasant conference. And let me welcome on the stage Petra Zape, policy officer in charge of healthcare, and Vlado Michieta, who is the chairman of the healthcare committee of AmCham, who will provide you with more detailed information. I wish you a pleasant conference. Ladies and gentlemen, dear Minister, precious guest, Mr. Dušek, let me welcome you to today's conference, which is extraordinary, and that is because we are going to summarize 2.5 years of work of the best experts in projects we called Health Data Value. We called it also a data map. Despite knowing that Slovak healthcare is facing many challenges, important challenges, we believe that anytime, more than ever, there is a need to have a vision and direction of the healthcare system, and we believe that data reform is the most important basis for clever management, planning, decision making, simply for better future of the healthcare system. In 2.5 years of common efforts and great adventure, in the positive sense, I was convinced in two things, and that's the trust and mutual cooperation. No system change would occur if we don't give a chance to trust, which will create the basis for cooperation and partnership, without which a common objective cannot be achieved. And I believe that the common objective for all of us is the better functioning healthcare system. Before I pass the floor to my colleague, I would like to personally thank to all healthcare workers who bring great added value to all of us. I would like to thank the Ministry for being courageous enough to embark on such a reform, which is truly key. I thank the NCZI for being courageous to overstep the shadow of the past and to create an institution of the future. Also thank the platform for providing mutual communication. All companies that invest into projects which contribute positively to system changes, and this project is an example of this. You can see all the partners behind me, and enormous thanks goes to the experts who for 2.5 years gave their time to this project. You can see them here. And to all people who, thanks to their decisions, support to our project, thanks to them, this project is a reality, and we believe that it's a good start for data reform. We are at the beginning, as Gabriel said, but we decided to walk, and it's an excellent news. Petra, thanks a lot, dear Minister, dear guests, ladies and gentlemen. Let me welcome you on behalf of the Healthcare Committee of the AmCham. As Gabriel and Petra said a lot, Petra was heart of all this project, and she deserves a lot of thanks for the effort to put all key people together, that this enormous project, as Gabriel said, we started to discuss, we started to seek solutions, and I agree with Gabriela that now the journey starts, and I believe that these 2.5 years of efforts will be one of the contributions to our healthcare being better, which I think is the topic of these days. Thank you again, I welcome you, and thank you for coming. Vlado, Petra, Gabo, thank you, and before we get to what we are talking about for 20 minutes already, I would like to ask the Minister for a couple of words. We are very happy that we took part in person, and we know that data is not his specialty, but the more we are happy that he's with us. Thank you for invitation and for your work, dear colleagues. Mr. Dušek, I've gone through the morning roundtable, even if it was square. I have a tendency now to modify this paper I have in front of me, but I will try to say things that are there. I think they are true, and everything that was mentioned initially I agree with, and data is the basis for us to be able to operate as we should. Even if it doesn't seem so, in many directions our healthcare belongs to the third millennium, not only thanks to the top quality of the healthcare provided in many fields, and I have to modify it slightly. I'm not sure if in electronization and informatization which simplify the lives of patients and doctors alike. The pandemics of COVID-19 showed us harder than ever before that modern healthcare cannot operate without data. That's why we want to, in this field, to belong to the third millennium. In order to do so, we need a data reform, which will enable us to identify sources of information and tools how to work with data and share them among all who need them. Our objective is to create a single source of quality and consolidated data. We realize, however, that we cannot achieve it without you, without cooperation with those who create data, who process them, and who use them or plan them to use them. Therefore, we plan to sign the Bratislava Declaration today and to ensure the future of data healthcare in Slovakia. A time has come to unlock all locked doors by means of high-quality healthcare data. This data will help us improve healthcare for the patients, make the healthcare system more efficient, and move the innovation in research forward. I have no doubts, since the quality healthcare data will help us start system changes in several areas. We've based the draft law on institutional healthcare on this. It served us in the creating of new map of districts with short supply medical offices, and it was the basis of the proposal to increase the salaries of healthcare workers. However, we want to achieve more. We want to achieve that the Slovak healthcare is managed and financed on the basis of objective data. We long for having one data source of truth and quality. We would like to use data for science, research and innovation in healthcare. Last but not least, we need to support high-quality international reporting by data. In all these topics, we will be talking, and you will be talking at this conference. I believe that the conference will be inspiring, and we will find the necessary solutions to be able to say that thanks to the data reform in preparation, we have healthier patients, better financing of healthcare, and higher quality research. Thank you very much. I will sit down and I will listen carefully. Thank you very much. Minister, I had one question or two for you, if I may. When it happened the last time that you needed some decision, you needed some data, and you didn't have it, or you had it late, or not as quality as, as necessary, last morning. Okay. How do you reflect on this square table, the conclusion you had that the cooperation between Slovakia and the Czech Republic could be much better? If you could share with the audience your proposal that you would come there and restore the cooperation which was started very hopefully in the past. Initially, I have to apologize. Data is a little more under the auspices of the State Secretary, Professor Babela, at the Ministry of Health, who keeps pushing me to deal with this properly, and he put me into picture to an extent, and today this round square table, and of course the presentation of Mr. Director, Mr. Dušek, reassured me that we have a long way to go and we need to grasp this more energetically also in Slovakia. And we've agreed to an extent that soon I would visit this institution and I will get detailed information how things are proceeding, and the colleagues who are in charge of this at the ministry will get deadlines and tasks they will have to meet. Thank you very much. If I may ask now, we are getting to the more technical part of the conference. I would like to ask Miško Štov to present the analytical part, the three phases of the project which was underway since summer 2020. I will hashtag HDV, Health Data Value. Easy to remember. My today's task is to keep the time under control. We haven't even started and we are already 20 minutes delay, so if I remind you of time limit, I apologize. But Miško speaks very quickly, just like me. Then I will like to ask Mr. Šesták and Lukáš Palaj to present the view on behalf of the ministry, and subsequently we will have a very nice presentation by Professor Dušek, who you will certainly like very much, to be able to see what is the situation in Slovakia and what is the situation in the Czech Republic. Thank you for the floor, ladies and gentlemen. Why we are talking quickly with Martin, because Eminem is our example. I was at the square round table in the morning, and for me, such meetings especially with Professor Dušek, get me to depression and wake me from lethargy, because we started in a comparable level, considering electronization and digitization, but we are still at the same level, or we are following the payments of the insurance companies for the insured persons that is dropping. Despite of that, I hope we get to the right level by this conference and realize what significant added value data has for us and what it means for us. We, with my colleagues, with Miška Lartišová and Maťo, 2.5 years ago, we started a project that concerned better data in healthcare, where we said to ourselves that it made sense to try to improve the quality of this situation again, because it's not our first, second, or third attempt, but that we would try again. And this time we were approached by someone, and we had the opportunity to cooperate with a greater spectrum of partners. But let's start more quickly. What's involved? Why do we need data, since time is precious? And you all are people who know data to an extent, and we don't need to mention this, why data is important. Despite of that, in the last year, I've been to many presentations, and each of them, at least in two, they mention data, 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 whether it's the state secretary Babela, who has this slide in each of his presentations, or other foreign speakers. Always the basis for any decision making, any processes, anything that's happening in healthcare, the need was to have robust data at the right point of in time from good sources.
As far as we are concerned, at least from my point of view, we look at data as something which cannot be shared, which has to be protected. We view data as a tool which has to help us to get somewhere in the right way. I was thinking how to correctly present the reasons why we need data. The point is that we have to consider the questions we need to answer, because these questions came from different stakeholders of healthcare, whether they are policymakers or hospitals. We needed to know which hospitals need to be transformed. We needed to know how many patients have a specific diagnosis, for example, in oncology. What are the associated costs? What are the associated social expenses? So all these data or all these areas show that we are lagging behind after not all but many of our neighboring or close countries. So we do not do not view data as something which is to help us. We rather view it as something which has to be protected and safeguarded. Many of you are medical doctors. You might have many questions about data. We, during this project, we tried to examine whether or not there is any feedback on data. So I'm mentioning that as the last bullet point, but as we all know that the first place belongs to the patient. Today we can talk about patient-oriented healthcare. It means that the patient is in the core, in the center of interest, but our patients do not really know much about their medical condition. However, the situation is improving thanks to healthcare, health insurance companies and other stakeholders. But anyway, the question was, the questions were not where the data come from, what are their sources, what is the availability. Answers to these questions are not necessary for the patients, they are needed by the professionals, by us, the analysts and other IT professionals, because we are those who had to try most, also respecting the GDP conditions and many different parameters, to provide the answers. So when talking about data, we need to provide them as soon as possible. They have to be up to date. An example from the National Oncology Registry, it has an update dating back to 2012. So the right question is, how many patients who are yet included in this database are still alive? We have heard some data from 2021 and partly from 22. Why? Because the systems have been partly automatized. Quality. We have many sources of data in Slovakia. It's not only a single source. We do not need to collect data on paper. The data or the reporting entities have multiplied data, which has a negative impact on the quality. Of course, we have to focus on safety. So yes, the data are of key importance for the decision making, but certainly not everybody has to have access to all the data. There should be certain aggregation of data. There are different levels where aggregation is not necessary. Let me now talk about the project. The Slovak data reform or data policy, we can say, what should be its direction in order to get more realistic answers? We have cooperated with a range of partners. We have divided the project to three phases. Miška and Martina, we worked on all three phases. Then you have Dr. Mišikova, who is with the Office of Healthcare Surveillance and Supervision. So this way we collected data from all sectors, who is providing what, who is providing the data to whom, what parameters are there, what the particular parameters mean, what they have in their background, and from all that we have compiled a matrix. I will show it to you in a short while, and after having that set of data, we decided to start or enter consultations with the stakeholders and ask them whether or not they are using such data, whether they have access to such data, what is the quality level, whether it makes sense to have such a volume of data in the present day healthcare. As you can see, the black ticks, the phase 1, phase 2 have been completed, and today we are in the third phase, which is the phase of implementation. Of course, the basic level implementation has to be carried out during the existing legal framework of the Slovak Republic, because there are different laws regulating the access to data. So let's speak about phases. In phase 1, we implemented 9,000 indicators, or we can say parameters. It might seem too much to some of you. Actually, it was more than 3,000, 3,500. And then we discovered that some reporting subjects or entities were reporting identical data. So we did the filtering. We tried to filter out the obsolete data or the multiplied data, data which we do not need anymore, but they are still reported from some reasons dating back to the era of dinosaurs. And finally, we put together a comprehensive Excel worksheet, including all the information, including the information on the frequency of collection, and we also reviewed whether there is anything multiplied, or whether there are some reporting entities which provide the same data repeatedly. And the key findings, and we have discussed that this morning as well, that many data which are being collected in Slovakia today are not consolidated. It means that they are not parametric. So many times we are filling out the text fields manually. There are duplicities in sources, which means that the doctor not only fills out repeatedly some data to different papers, and then he is doing the same thing quarterly and every 6 months, reporting it to different agencies. So it doesn't really make sense, because it results in obsolete and unnecessary data. In phase 2, which was more complicated. We have held meetings with different companies and discussed the findings. So we told them that, look, this is what we collect, and asked them that, what was your process? How did you proceed? Were you manually filling out the information, or how frequently? For example, somebody filled out the data in January and didn't do it anymore during the year. Then we asked them about the qualitative checks. If there were no quality checks, whether they have seen any outputs which were fruitful or helpful, or and in the first moment we saw that most of the data collected in Slovakia and which are being used are collected duplicitely by the insurance companies. I hope that our colleague from the Czech Republic will also tell us what kind of data are collected and used in the Czech Republic. And the approach of the reporting entities to data collection, just think about what would be your motivation to fill out anything honestly and perfectly, knowing that nobody really cares. Even if I write x plus 10 and nobody is going to deal with it, so the motivation is not really high. An important point was that most of the companies we discussed were ready to prepare their data requirements. So actually they are ready to prepare providing better quality data, and we together try to achieve the both-way data stream. And we hope that we will be able to reach some data outputs which will be moving us or getting us more forward. Some data were prevalence data, incidence data, which today we can get from different sources. Nevertheless, we are not doing it. We will get to that in the final part when Mishka will speak about duplicity data or duplicated data. This is her field of interest, and she will provide you more detailed and exact information. Then we discussed that we need to find out whether something you prepare is really functioning. And that's why we launched the project, the pilot project at the National Oncology Institute. And today we can say, National Oncology Registry, excuse me. And Professor Dušek had a great idea to move really quickly and automatize the last 10 years and quickly get to the current state. We are thinking about establishing a data hub which would include all the information and allow access to different users. And of course the legislation which is in the process. We have colleagues here who tried really hard to help us to draft the respective pieces of legislation in compliance with the EU regulations in order to limit as much as possible the shortfalls or the failures which currently we have. We all love quotations. There is one about the data. If we have data, let's look at data. If all we have are opinions, let's go with mine. So let me finish by this quotation. Mishko, thank you very much. Questions? We will have a 50-minute short panel for Q&As. Of course, we have plenty pictures, to illustrate the words of presentations, and before lunch we will have a chance to go through the visual materials as well. And now let me ask Lukáš Palaj and Matúš Šesták. First Matúš Tára to say a couple of words on behalf of the ministry, and then please pass the floor to the State Secretary of the Ministry of Health, Director General Matúš Šesták, in charge of digitalization and informatization at the ministry, who is welcome to give his speech. Thank you very much for the opportunity. First of all, I'd like to say, without repeating the information which have already been said, that today the sector is in an alarming state or alarming condition. I think I can use such strong words because those who know me know that I don't really insist on a diplomatic vocabulary, because I consider very important to talk openly about the challenges. And I think that this morning during the roundtable, the minister listened to all these issues. I would say that we have to start the process of changes. One of the challenges is that the data we have available are not consolidated. Our ministry have 130 organizations in its competence. All those institutions collect different data, and then with such a volume of data, it's very difficult to decide which data are more important than others. And sometimes it happens that when we finally receive the data, they are not matching. So when I joined the ministry, I started to examine what could be changed. And the first thing I checked is what is the title of the resort, what is the title of the sector. And I find out that from 2007 there is no strategy. There are no standards or limits defined, which are of key importance today. Those of you who work with IT sector, you know that the development of this field is so rapid that if we do not start to move quickly, we will not be able to catch up with the developments. So what our department is preparing is the digitalization strategy. Of course, this strategy is based on data. However, these data create systems, and it is sad to say, but the sector, the ministry, doesn't have an overview of the current status of the data. What is the infrastructure? We do not have any overview of what our subordinated organization provide, and all these things have to be changed really quickly. They have been already first steps made to improve the situation. We need to have an overview or a global picture, overall picture, and the vision. The vision is important from the financial point of view, because as we lack the adequate wages for the healthcare professionals, we also need resources for the infrastructure. Without a massive financial injection to the system, we will not be able to talk about or improve data, because as it was said earlier, these data date back to the era of dinosaurs. I don't know why these topics are underestimated. And I don't envy the minister, I don't envy the Secretary General, Mr. Lukács, because we don't really know what to do first and how to start improving the situation. So based on the activities we have launched at the ministry, early next week we want to develop a strategy incorporating different stakeholders in order to create a joint output, including the vision and the strategy. You know that over the last 2 years, at the position of the Director General, there were four different people at this position, and really it's very difficult to create anything if we have so frequent personal changes. We cannot plan in a long-term horizon. So we urgently need a vision which the sector will consider its own, and then it's not going to be about me or about him or somebody else. For example, if today at 11 the minister will sign this declaration that we want to take the first step to the third millennium, really we need to have standard data on international data based on IM profiles H7 standards. We know that the entire area and the EU countries, we talk about European data space.
And we are talking about the debt we need to eliminate as quickly as possible. I would like to pass the floor to my colleague Lukáš, who will tell you more about the data things from the perspective where we need to get. I needed to say that the ministry will shortly make great efforts to eliminate the debt. We have a national project approved to support these solutions to as quickly as possible to be able to massively support human resources for the for the healthcare. And we also wanted to convince the Ministry of Finance to massively subsidize us. Last but not least, we need to talk about there being a sector that is stagnating, that needs help, and together with all of you, I hope we will manage to do so. Thank you for the floor. Lukáš, the floor is yours. Does it work? It does. I think I would need the second presentation or another presentation. I didn't introduce Lukáš. He's the Director of Artificial Intelligence at the Ministry of Healthcare, and he worked with us since the very beginning in the project. That's all. I would like to ask the production to display the presentation. If it's not available, I can present the previous one too. Before it comes, I will start. I will try to be constructive and optimistic because in my opinion, we have started well. It's still up to us what to do about it. To summarize it into two basic pillars, I still think it's the previous presentation, but we can go on. I have a clicker. It's the complicated one. So I will try very quickly summarize it, and let's say start here. If I was to summarize the vision of the ministry in 2 points, the first would be integrated data ecosystem. I think this is the basic pillar where we need to start. Just like the General Director Šestak mentioned, the integrated data ecosystem starts or is based on data standards. Currently, we have very many sources, a lot of data is collected, but the problem is that data can mean something different in Košice or in Banska Bystrica, and that's why we need a unified standard across all stakeholders. Oh, that's it. Exactly. This is what I wanted. And the second pillar, which I would like to emphasize, is the subsequent use of this data, sharing correct data to the right stakeholder in the right time. And I will help myself with a picture which I copied, I confess, from an article that is mentioned below, but it illustrates the situation very well. On the left-hand side, we see silo-based data. This data is somewhere, it's worked with, but even within an organization, it's difficult to share them and exchange them, not let alone within the entire sector. What we need primarily is to introduce such standard in each organization to be able to create what is on the other side, that is an integrated system which supports interoperability and subsequent applications, whether in the form of AI or other tools. What is the second essential thing is, as Michal mentioned, a lot of data in the current e-health. You will see there are millions of discharge reports we cannot do anything about because of the complexity of the system, and secondly, because it's non-structured text. In Slovak healthcare, we need to start introducing structuring in data collection. We need to note that this is not an IT problem. This is a change management problem. Much greater problem is to teach or to introduce this in the practice so that the end user sees this as a value, why he should enter such field in such a format. We don't want it to push it on the doctors. You start doing it this way because we need it, but very gradually, step by step, to introduce the structured data collection in the given standard in order to be able to then work with the data for the good of the patient, for the good of the doctor and the system. In order to be even more specific, that it's not just phrases and wishes, but we have specific projects which already we are implementing, we already work on, in order to reach this holy grail. First of all, I would like to underline the vision of paperless Martin Hospital, because our idea and objective and longing in which the ministry wants to help is that this hospital is an example to all hospitals in Slovakia, that this is how it can look like and this is how we want it to look like. This is the first point. And this hospital is already being worked on. The second point, which I think is very key, is the project of cardiological information system. At first sight, it doesn't need to seem related, but this project is to serve as a pilot implementation of quality indicator evaluation, which was found in the optimization of a hospital network. But in order to do this, we need to collect the data structured. This is the basis for something like EHO 2.0, where the data will be in the standard and will be used and published. There are other projects too, I don't want to talk too long, which support it from other data sources, because it's not all about structured data. There is also imagery data from imaging techniques, etc., or through different wearables or implanted devices. So all this is directed there, and it is something we work on. The second point was the correct data to correct stakeholders at the right time. And again, There are activities already which we are undertaking in this direction, and it's the project of data map or health data value, which is not ending at this point, but it continues, and we want to develop it, and it's related to the European health data space concept. Enable the data to be used by a broader spectrum of people for the good of everyone. And this is related to an activity of which some of you may have heard, and that's the Healthcare Innovation Center, where we want to connect different stakeholders, not only from the state and public sphere, but also from private and academic sphere, in order to be able to come up with innovative solutions. And the last point is the legislation, primarily amendment of the National Information Healthcare System law, which is already being dealt with, but I believe it will be repeatedly adjusted in order to iteratively improve it. That much I hope I was specific, practical and quick. Thank you. Since we still have time delay, I would like you to sit down and postpone the questions for later, because there will be a single session of answers. Now I will summarize that we have a ton of data in Slovakia. Part of them is either obsolete or in a structure we cannot work with. We have a big problem with, let's call it, compatibilities or possibilities of work over them. We have a problem with change management, and these are problems that our colleagues in the Czech Republic had, but in 2014 to the Czech Office of Healthcare Informatics and Statistics, Professor Dušek started to work at, and he eliminated many of these problems gradually, and I would like to invite him to speak. I would like to introduce him in addition to being in charge of this institute. He's also a professor at the medical faculty in Brno, and his CV in abbreviated version has about 5 pages, but these are the key things I would like to say about the professor. And since I had the opportunity to see the presentation, it was very inspiring, so I'm looking forward to it. Thank you for invitation, dear Minister, ladies and gentlemen. I don't deserve this praise. My CV is 5 pages in unabbreviated form in a 16-point font. We have often data in unstructured form in the Czech Republic. We don't know what to do about them, and I don't want to this presentation to sound as a presentation of a champion who would like to teach you. I am presenting with humility, and thank you for the invitation. I like Slovak nation very much. It's not some envious, it's more honest. I've been coming to Slovakia and worked here as an analyst, and I liked it very much, and I hope this time to repeat if COVID permits. I give you the greetings from our minister, Professor Válek, who would be very happy if we started more intense cooperation. And now, only very quickly, I prepared about 600 slides to different calls, and if someone had epilepsy, seeming that I'm showing it too quickly, there are many examples of data value. I was asked to say what is happening in the Czech Republic, and when I came to UZIS in 2014, I said, the minister, we could shoot Pirates of Caribbean, and we didn't need even a masking. All data was collected on paper. I had mortality data brought to me because I thought mortality would be best to start with, and they told me they cannot send it to me, and they told me I had to go to some wagon and find it in some folders. So is it not electronized at all? It is. Yeah, it is. We receive the letters of dead bodies examination and we scan it. But there is a problem and you need to deal with it. It doesn't have standardized grams, the paper, and what we need to copy it first before we scan it. So we were copying 120,000 sheets, then scanned it and then electronically send it to the statistic office. Today, of course, it's all on wires, and the doctors welcomed it because except where the uh, emergency service uh, fills in paper forms, we don't use paper forms at all. What I want to say is that we didn't go the way or the path by revitalizing individual agencies and getting them one by one to electronic form, because we would end up with hundreds of symptoms and thousands of different diagnoses and sub-diagnoses, and if you were to make a register for each of them, you would crash. And the time we are living is the e-health time, electronization time, and it substantially changed the position of healthcare registers as such. When we were starting, that was long before I came to UZIS, the single source of sophisticated clinical data was the partial clinical registers in the Czech Republic, which were collected manually to some database perhaps, but using healthcare terrain, which of course is the pathway to health. And what we started and what is living now is to create a central core of the system which will pump automatically as much data as possible and use the partial registers, including the national oncological one, as additional collection of data which we cannot fully automate because it's not possible at all. And this is the philosophy we are bringing, and it's not for a Nobel Prize, it's a common thing, and anyone in who was in Finland, Sweden, Norway, Denmark, and even Albania, I will be able to say soon, they have it everywhere. The core of the nationwide systems will have to need to be here. And how do you answer someone? Why do you prefer National Oncological Register? Does it seem to you more important than the cardiology? I would have difficulties to answer. Oncology is not a great cause of health. Does it seem more important than diabetology? No, there are more diabetologic patients. We could continue like this forever. Of course, the way to this victory, so to say, was through essential changes of laws, which were not ready for that, and you cannot work without laws in even in the GDPR world. No system in the healthcare of the European Union will be sustainable unless it generates, if it generates redundant load for the healthcare terrain and for doctors and nurses. Slovakia is in the same situation. We lack nurses and acute care. We lack doctors. The minister told me it's even worsening in your country now. These are things you can't deal with by each register or idea moving on to the doctors. And still, it's a place where we are failing. And I'm not standing here as a champion. We are still loading the healthcare terrain by some collection, and it doesn't care if the doctor fills it in paper or in a web interface if they do it in the evening, and additionally, if it is not fed automatically by the hospital information system. You can find stories there that are even from zoology. What we tried to do is to create a data core of our healthcare with respect to healthcare itself. This could be taught to small children. This is healthcare. I drew it myself. I didn't invent it because sick Dushik comes to his GP. They both both know each other, they know everything about me. I say he's a good doctor, I can be cheeky to him, but he provides care to me. But it's always the provider of the therapy who provide it. That's why, because it's a hospital about it, above it. Now you should transfer it to electronic form where Dušek doesn't come with his 80 kilos to the doctor, but there is some data message from Dušek. It's not quite as simple because you need to arrange something that is automatic. He looks at me and he says, again, Dušek, what happened again? Do you need antibiotics and go to work? Yes. It doesn't work that way. He needs to identify in the electronic world. You know it better than me. The colleagues are experts in this. But the electronization of this simple, but the most important provision of healthcare in real time is not quite simple. If you start put partial registers into this system in order have nice PowerPoints on conferences, we crash because the system will not be able to handle it. Too much revolution, and healthcare insurance come against some academician who doesn't reflect the reality in healthcare. It's not that way. You see, healthcare in your and our country is controlled by healthcare insurance company. It's good because it's solidary, this public healthcare, and there is enormous system which has right to suck in data. I cannot convert it to euros, but they distribute enormous package in Czech crowns, and they have full right to suck in the data, much greater than me who wants to do PowerPoints.
And this player has to be respected. The system has to be under control and in a humbly way. So when started to set up this system, we standardized the real-time regime, which includes doctor, system, patient. Then we started adding data and interconnection with the health insurance companies. And then the remaining part, which is data collection, should be something additional. It means that to collect data which the system does not provide in the first run. So we had a question. Somebody asked the state secretary, state minister, when it was when he last time needed information, and he said yesterday morning. So in my case, it was this morning, and it reminded me raised the question that why we do not collect the injury score, polytraumatic scores. That should be also important. So when I enter the system, so please enter ICE at the top level of the system and ask the doctors to fill it out. This is the worst thing you can do, because then we are asking to fill out different genomic data and other data, and that's wrong. I think that this part should be sacred. This should be the most important, and they should be data in real time. And then this ICE had to be somehow pushed into the standard and get it up to the automated level. And there is only a few cases when we enter the system from the top and then move downwards in some special case of leukemias, which are individualized and which must not be automatized. So this is the core which I wanted to introduce. This is not from my head. You can find it in any medical textbook. There are different levels. The first one is the authoritative real time. This is the basic healthcare, which is switched to the electronic or transferred to electronic space. Then we have this referential data, which include huge data packages. For example, when I retire, and this will most likely to be because of COVID, then these data from the retired people will provide many information to the system. And this is my beloved slide, and you can see the Czech flag. This is the national system of healthcare information and its basic structure. It centralized the data from all insurance companies without any objections that this is not necessary or that is not needed. So we are in a partnership. Each and every insurance company in the Czech Republic can confirm this. When I came into the ministry, it wasn't, or into the system, it wasn't the case, but now it works. One act of legislation has been adopted and now regulates these streams of data flow. I don't know how is it in Slovakia, but we didn't do the hysterectomy of men, and we have not yet applied to the Nobel Prize and even paid by the insurance company. It means that this referential network has its charm. I will get back to that. And other systems. At the beginning, there was a change or amendment to laws. As you know, that the legal system can teach the really proud academic to be humble. So here you can see this law, which is marked by an arrow. It's so fresh that it's still steaming. It was developed during the COVID era, and now we are in the phase of implementation. I expect you will ask me complicated questions, and I think I will cry in the discussion because this doesn't work well. And I am also proud of this picture. In 2014, I only had this part, then I draw the rest, and then I draw the upper part, and finally this bottom part. And these are this electronic real-time data. This is the data storage of all insurance companies, and were filled out back from 2010. Even so, if you will be told that it's not possible to do it retrospectively, don't believe it, because it will be where you put it. So if you define it in the law, you can use font number 5, ideally in the white paper, and that will be reported retrospectively. Provided that in 2018 the insurance wouldn't approve this process, I wouldn't have a single data here. But since it was approved and the insurance companies actually implemented it, we have now the collection of data from 2010. It means that any operation or action, any interaction is here. Here we have the standardized hospital systems, but I don't want that to see too megalomanically. We have a national system with certain level of standardization on the level of hospitals, but we are far from the standardization of the internal operation of hospitals. But I believe that if somebody happens to standardize this level, the data will be directly pumped into this system. Here we have a support of organized healthcare programs, so they need a specific information system. For example, the DRG, you know what is it, or organized programs of screening or palliative care. And this is a kind of three-dimensional structure we try to fill in with data. This is the holy grail of healthcare services. You see that in the center of this model, there isn't a patient, but a particular document. So if somebody has a surgery made on a teeth, we can see which tooth it was in particular and what was the surgery focusing on. So the question is whether there should be any partial clinical registries. The answer is yes. It will always be necessary to find some partial data, and but not for everything. It is not necessary to have partial registries for everything. But in the Czech Republic, for example, we have this registry, but nobody is using it, and that's why nobody is filling it up with data. If you don't believe, I will show you this slide. Step one, from the insurance companies, all the data go to data on the diabetes, specific diagnosis, specific treatment. It means 99% of administrative data are covered. You can see whether the patient is treated by a professional or specialist doctor, how often he goes to hospital, etc. Then we have data on laboratory. So this is the flow of data from the labs. This is in the process. It has not been completed. You can see all the tested substances, hemoglobins, etc. And we will comply, or I mean, we will complement the data only if needed, if there is a special study made or anything. A different story is the National Cancer or Oncological Registry. At least 90 diagnoses, all different, very complicated system of validations. And in the Czech Republic, it's currently automatized. So it means that there is clinical workplaces. The law establishes different data. 2020 is completely completed or fully completed, but it's not operated fully. But I hope that most of the professionals now understand that this is the logical way, and there will always be a need for a central which will validate these data. The data differ, but this is not because if somebody lies, but because all the tumors can differ from each other. The pathology of tumors differs. And that's why this collected data has to be cleared. And I still have some 10, 11 or 12 minutes. I would like to talk about the value of the data. But I don't want to look like somebody who arrived here to spread the wisdom. I just want to show you what we actually use. So, information support for disease management, and I decided to talk about cancer care, which is spread across healthcare. In cooperation with the Slovak colleagues, under the umbrella of joint actions of European Union, many of you certainly know CANCON and our ICT comprehensive model, which is the data pump, which was piloted in the IPAC for Europe. You can find it on the internet. There are different websites containing such information. There are some pictures from our conference. That was a kick-out conference back in 2012, participated by many European colleagues. This is just to say that it has not been launched, that the Czechs decided and succeeded. Without the support of the European colleagues, we wouldn't succeeded in achieving our results. We have Professor Brenner, Lucia Zator, a significant oncological professional innovator in the field of oncology who provided a lot of help. Comprehensive management means that we cover the entire oncology, starting from screening, through prevention, through the circle of primary care, etc., etc. The first output, epidemiology. Here you can see what I mentioned, that the system or the set has been closed for 2020, but the system is not fully running, but it has been completed, and you can see that we are a nation with a lot of tumors. Unfortunately, this is the sad reality. You can take a closer look on these pictures on online portal. This could be also implemented in Slovakia because we have the same database. The oncology has been followed in the National Center of Healthcare Providers. Here you can see the complete interactive maps containing all the workplaces. This is the hardware infrastructure. And you have seen this already. We have standardized data models uh, to export all the data from all health care workplaces. It means that I am able to get hold on all the oncology data from all facilities, hospital facilities in the Czech Republic, from the entire system, so to speak. And all that is covered by the comprehensive map of outcomes, which is a source of interpretation for different statistics. I'm really proud of this system, which is monitoring the screening programs. Nothing is done manually. The screening programs are starting here, and it works backwards and forwards. It backward means that all insurance companies have implemented our software developed by Masaryk University. My distinguished colleagues, Dr. Vrabec, about 500 years ago, that the positive outcome is that all the insurance companies have implemented or installed this software, and they send us letters. And here you can see that if a patient is physically arriving to the hospital, all the data go back to the insurance company. And here we can get an overall picture of the screenings, how successful they are. The screenings are going on. They can save 30% of lives of the people, but I believe they should be even more effective. Here we have the population level reporting, all different epidemiology data, including the screening, different monitorings of the survival rate. And in these websites, you can find all these monitoring data for 2021 for the rectal screening, for FOV positivity, for age-specific detection rate, compliance of colonoscopy, and the rate of share of different specialists, etc., etc. Basically, without the data, it wouldn't be possible to launch new screenings. This is exactly the data value. Here you can see that in Czech Republic we can harvest the carcinoma of the tumor of prostata, and we are not getting forward. This is a non-organized screening. This is a, so to speak, wild screening or unorganized screening, which has to be put on a more or higher organizational level to avoid chaotic data. Here we have the first part of half of 2022. Rectal carcinoma is the diagnosis which is the greatest challenge, decreased during the COVID, and here you can see displays. This was the increase of the screening colonoscopies in the first 6 months of 2020. Well, these are the FOET colonoscopies. In other words, it's actually the harvesting of tumors which had to be diagnosed in 2 years ago. So some specific examples. I had Czech slides. There is one particular center of the faculty hospital in Brno. Here you can have the mapping of the data, stabilized mortality, really steep increase of patients, 3 to 4%. These are data for 2020. Here you have the new tumors plus 20%, the prediction 35% in the next 10 years. This is a really negative prognosis. This is not even a prediction, this is a kind of estimated increase. Here is the trajectory of oncologic hospitalizations compared to the state of residence. Here you have the South Moravian region. Here we can also see some regions with explicit problem. For example, Karlovy Vary, Central Czech region, especially Karlovy Vary region. So this makes it possible to compile such data. This is from before the COVID at the turn of 2019, quite positive. Here we see the position of primary care centers in the Czech Republic.
In the category of oncological centers, this center has position 2. In the category of hemato-oncology, it's the largest center in the Czech Republic. We can see that its load is not only given by incidence, but also by prevalence. That's essential information, because the cost is driven by prevalence, not incidence. And in the hospital, you can see that it's the main problem. We can see the collection area of this hospital. It can be at the level of individual diagnosis of individual groups. If you were interested, I could be showing this until the evening, but I would never leave Slovakia. And we can see the relatively above average survival in selected tumor groups. So this was just a brief sample. Value of data. Data has its value in predicting costs and predicting highly innovative technology. We have a system, CZ diary, introduced, the CZDRG, that is, which I took as a punishment, and now I am happy. My colleagues managed this. You can see transparently on a portal. You can click through individual groups, bases, its structure, and what is most important is the reference network of hospitals, which belongs here under 5. It's connected to the national hospitalization register. Its data is validated against insurance companies, cannot lie, and it collects all consecutive cases, total striptease. Then we collect detailed costs. I will be happy to show it to you. That's the holy grail of our efforts, that we have collected from the reference network enormous data. In the database, we have 4 million hospitalization cases, covering 40% of acute bed care. We can see operations within minutes. We can see costs of drugs, enormous work of hospitals from which we derive the economic models. This is just for you to show you that I can do a complex picture. This is the validation system that validates data, and if you want, we can go through it. You don't, and what a pity. Your pity. Innovative therapy and their prediction. We have a special system for this, including horizon scanning, and this is the structure. It has its epidemiologic part, reading the growth of man months with expensive treatments. We work with months parameters. This is the growth in individual segments. All this collect or closed at the end of 21, used for predictions. We need to monitor the unit price because there are price erosions and gentrification. How these models work, it's not just praising ourselves. We predicted progressive development of costs in this area of highly intensive care. No one believed, and in 2018 it was about 26.95 in 23, and the development of data shows undoubtedly that in 23 it will be 26 billion. So the models clearly work. No one had to collect anything manually, so this was pumped automatically and we just work with it. And crazy disaster, I had my deal during COVID. It's a miracle I am standing here. The deep view into the essence of the Czech nation, especially the evening emails. But I want to show you just one example. During this period, the Czech healthcare was forced to switch to a real-time regime. Let me show it to you. For COVID, we had to create a completely new information system because all that I showed you was a little vintage. But with COVID, it doesn't matter if someone reports to you in a month. You need it hour by hour, and we were not set up for this. We developed the system in the first half of 2020, and these are parameters which are collected real time, and it can cover any vaccination, injection, any uh, conta- any outbreak of disease. So it's done hour by hour. Martin saw it in Natura. These are two publications that were published describing the system in detail. Why I am showing it to you? This is an example. I want intensive care to work like this, and this is it. I called it in Czech that data can overtake a virus. At night, all standardized laboratories provided data on all captured COVIDs. In 2 a.m., server transferred it into the pictures you saw, and each individual positive case was found in the insurance company's data, and we immediately knew if the particular patient had oncological problem or anything else, diabetes. Uh, what you can read in this article, the models worked fantastically. We assigned risk to each person, and the model had 95% success rate. When we said this person will end up in hospital within 10 days, it was almost 100%, and slightly less success was in intensive care unit predictions, etc. It was a military school with an army. I never was in the military service. I became a fun club member of the army. With the general, we built models on this, which reported to the National Coordinator of Intensive Care how many new COVID cases we had, which in 5, 10, 14 days would end up in the intensive care unit. And it was reported to the network of regional coordinator, and they prepared beds through regional dispatching. So I remember crisis committees. It was done at night when I said in South Moravia to the hetman that he would need this many beds. I said you had high risk cases, you will need 200 beds, and they needed 218. If they didn't know in advance the breaking path takes days. The epidemic didn't end up in the Czech Republic. Death rate was disastrous, but if didn't work, the mortality would be 3 times as high. And the conclusion, I was forced to do this not from me. I'm at the end with the time. We are going to enter the river which will connect health and social data, because we have the separate ministry and gestion, which is a disaster, but it cannot be changed. In Europe, we are the only ones, and we started to do it on the model of palliative care, end of life care, where social care and medical care plays big role, and we monitor through our system only the healthcare part. The social is a black box for us, and now the ministers agreed that we would connect it. The data doesn't show nothing nice. Look at the spots in the Czech Republic. That's the availability of palliative care. as if we were three different countries. There are many problems. We started to map the trajectory of the patients in the system because our NZIS can do it. We can see a person before death. We can see that he has predictable death in 6 months or 1 year, and we map how he travels through the system. And palliative care people taught me the required or desirable trajectory and undesirable trajectories. And in the Czech Republic, it looks like this: 38% of the trajectory is desirable and 62% is undesirable. And it's high time to do something about it, and we cannot do it ourselves. It's an interconnection with the system, and thereby this adrenaline plan was born. National Social Information System. You can see that my creativity has been exhausted. You can see it in the logo, and you can see it in the inscription. I don't know what font it is, but it randomly landed in some spam. I like it. It's ANSYS. It's like ANSYS. It's brother, a reference network of providers. It's in ideas, it's just being born. And the last thing I want to say, as the law on electronization of healthcare is the master, we will now be writing, my colleague will be writing law on electronization of social services. And the two, as brothers, should be templates and interconnect the data stores of both ministries, and the ministries can remain separated. It doesn't matter if you interconnect the data, it doesn't matter how many buildings you have. And I hope we will manage, and Professor Válek and all the government and the Prime Minister Fiala, who is a professor of my university, my former rector, is in favor, and he believes we can do it. I will be very happy to work with you on this. I extended my time. I apologize. Never invite me again, perhaps, but I appreciate receiving this space, and I hope I was humble enough in my presentation. Thank you for your attention. Without these precious gentlemen, it wouldn't happen. One next to each other helped us very much, also in political assertment. Thank you, Professor. You can sit down, because I have a couple of questions to you, and then I will ask the other panelists. I will remain standing. I would like to see the rest of the 600 slides, and I am at your third presentation in last 2 days. The topics you presented, whether automation of onco-register or pulling data from the bottom, from healthcare insurance data through algorithms, these are topics on which my colleagues, we were working actively for years, and we failed. And these are the main recommendations and conclusions of our first and second phase of data project. Historically, and we still encounter resistance. It cannot be done. It is not implementable. So I am happy that from Bratislava, you with your team are an evidence that it can be done, and we all saw what enormous added value it can have if it works. If I can ask you one or two questions and then invite the colleagues. The first is, you know the Slovak healthcare very well. Not once, whether the Minister Kalavska or Docent Šuvada tried to use your knowledge, what are the three greatest shortcomings of our data IT systems in healthcare? That is a very difficult question. I don't feel in position after COVID, when I lost contact with the world. For 1.5, we slept 3 hours a day and we did only COVID. I don't feel educated enough to say anything about it. 3 or 4 times I was in project when screenings were started, organized screenings, organized prevention. Last time with Professor Šuvada, where we obtained a European project which launched this, unfortunately, and ended up in 2019 successfully. There were methodologies, task forces were operating at the ministry. We had software for monitoring, which never happened, and then COVID came, which killed it probably. Half a year ago, I was at a urological conference here, and for the first time in Slovakia after 2 years, and I saw important Czech and Slovak doctors presenting that they didn't know how many patients they had, and if you don't know the answer to questions, how many breast cancers you have by districts, by regions, in 2021, in the first half of 22, if those that are in charge cannot answer this, there is no screening, there is no coverage, and it may be subjective, maybe I see it wrong, maybe something is there I cannot see, but the urological conference was very depressive for me. The important doctors were showing data from 11 and they didn't have access to this data, and the insurance companies were saying they didn't have access to this data, and I think this is a small thing, but it's big. The three screenings in a year, you have it, potential in the Czech Republic is 20,000 man years to be saved. In Slovakia, it's a half, 10,000. That's something. If we just completed this single thing and you started population-based screening for selected tumor diseases, it would be good. I had a feeling in 2019 it would be working, but now I have feeling that it doesn't. Please do sit down, and if I can now invite the other panelists, we'll have to shorten it up to be able to sign the declaration on time. I will ask the State Secretary, Professor Babela, and the Director of NCZI, Mr. Lukács, to join us so that we can develop on this topic on the highest executive level. There will be more questions. Maybe I will ask for one extra mic and we can start. I will start with the General Director. We have heard a lecture what the Czech UZIS plans. What does the Slovak NCZI plan? Thank you for the question. I would be very happy if we could distinguish between some things. What we are talking about now, how it could look like, how it could work. If we look at the banner of NCZI, which is on my right-hand side, the only thing that works is the Slovak Medical Library. And when individual approaches were defined, that we should be introducing norms, standards, ensure digitization, these things are in existence, but they are not, as it was presented, communicated in the form of some structures. It's just plans or methodologies which are outdated, which doesn't provide what we need today, and that's current, high quality and healthy data. I understand that it's very difficult to move the negative opinion, the PR of NCZI, that we are going to do something again and we don't know how to do it. We started to reflect on individual outputs which concern the third phase of data map, and what today is in offer is the position document, which includes 4 pillars, and I would be happy if we could start jointly with the partners participate in implementation of these pillars, because this is not the strategy, it's just the definition of the position. What we are talking about today, where we should be today, and we are not there yet, and that's why I consider important not to come up with a strategy that has not been communicated with the partners. Initially I said that I want to have transparent partner communication, but what is necessary is to make the setup. We can define 1 million objectives, we can define unreal number of electronic services, but unless we see behind it what I want to emphasize, why we should have 60, 100 different electronic services, it doesn't matter the quantity, how digitization work in healthcare. It doesn't matter how many of the services are there, but important is the services fulfill their meaning, so that doctors do not reject digitization because there is lack of motivation. What I changed my opinion was, yes, it is important to know the side of the medical doctor themselves, but I realize one important point. The most important link in the chain is the administrative healthcare worker or the nurse who helps the doctor to enter the data. And when the nurse tells the doctor, I'm not going to use this information system because I don't like it, we start collapsing. And the position document I'm talking about is about the understanding, or it's a transfer link of the data map, how we want to proceed. We provide space for partners so that based on the pillars that are introduced there, we offer a strategy. I would be happy if the strategy was a document on which there is agreement of the entire expert terrain. What is happening here? Whether it's MIRI or the Ministry of Healthcare, we come up with some methodologies and we need to explain how we mean it. And I would like the strategy to be one high quality document which doesn't shoot Digital Slovakia or MIRI, or is doesn't shut down by MIRI or Digital Slovakia or other partners, but it's something that we want to get in 2023. I suggest that the declaration has a political approach, and we may need not only time by 2030, but maybe 4 political cycles to fulfill this.
Thank you. If I may ask Professor Dušek, who is the person who decides in your institution the direction of, or in your country, the direction of data policy? So in the first place, it's the parliament, and then USIS, and the academic sphere, or some IT professionals. So basically, it's the parliament. It's not the ministry. So any data policy has to be supported by law. So since we have the GDPR in place, it's a must. So whatever we want to do with the healthcare information system, we have to do it professionally in cooperation with professional technical companies, and to present to the parliament following the public discussion. So first of all, somebody has to do the work. So if the general medical public says it's okay as it is, the next step is to present it to the parliament. So if I understood you correctly, so you as USIS are in contact with the technical companies, then it is presented to the parliament, and the parliament is to make the necessary legal changes. Well, we are in the contact with all the stakeholders, medical professionals. I am traveling across the country. This year I will have 9 presentations. So when I came to USIS, this brand was ridiculous. It's not enough to design a logo and to shout. In the space, you have to really go and travel and tour the country like Cyril and Methodius. And then this process started to get a practical form. So excuse me, I try to modernize my saying. So this is the saying that learn, learn, learn in a form of present, 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 lecture, lecture, lecture. Well, this is a really comprehensive discussion in our country. Who is or who should be in charge of this process, whether it's the ministry or the National Center of Health Data. So thank you for your experience and input. There was also an idea to establish a virtual ministry, if I understood correctly. Exactly, this is really a concept or a proposal. It is subject to discussions with colleagues. So we are now in the process of netting. And the minister, who is a distinguished expert, has approved it already. And my first steps will lead me to the GDPR authority. During the COVID, provided that we were not prepared adequately, that could be really bad. Our discussions will be really in depth, and as soon as we do this touring I mentioned before, do many lectures, and we arrive to some conclusion, we will present it to the Parliament. So pharmacology is your specialty. I know you from the times when you arrived to our IZB and you asked us whether we have some data. And I'm asking now whether your ministry have, or whether your minister considers some inspiration from the Czech Republic. Well, this morning it was said already that having combined data could be really useful for us. However, we would be happy to have at least the basic data for all the spread diseases or epidemiological data from the diseases in Slovakia. And we need it when we sign the contracts with the producers, and we are just estimating the potential number of patients in the future, while the Czech Republic has predictions already. So basically all the models are bad, but we have to start out somewhere. And that's why we would be happy to make a step forward in this field, because it is also linked to some data on the expenses, some data for the social insurance company, because a diagnosis like stroke or and myocarditis increased in more than 30% recently. And we followed our Czech colleagues, and we consider really good what they have established, and this is the direction we would like to go as well. We hope, or I hope, you will succeed. And if I may, I would ask another question concerning the signing of this declaration. Did you have anything similar in 2016? Because if I remember correctly, you might remember 8 or 9 ministers. Well, yes, I'm really persistent. This is my 9th minister. So the ministers really take turns really often, but this is just a joke. I don't want it to sound embarrassing, but when I arrived to the institution, I had a really stupid idea that I'm going to make a change. And my colleagues tried to correct me or put me right, because my idea was really wrong. I had nobody to talk to. The USIS didn't have correct data. The doctors were not happy. The doctors were writing emails and making phone calls. There was no declaration, there was nobody to discuss these issues. However, I was glad that the then minister, my dear friend, Dr. Němeček, then didn't have any resources to do such a thing. And he just said that I will give you a green light to apply for grants wherever you want or may. Uh, that time we wanted to join the Health 2020. There were some remaining funds available, and from there I managed to get some funding for this project. Without it, we wouldn't have anything. So you arrived and you gradually tackled the problem. Actually, well, as it is said, I write on an A4 size page, and I said that whether we are going to collect it like really in a really primitive way on a paper, or we will collect the data. The state secretary want to join this discussion. I don't want it to sound negatively, but we had a similar experience when 1 year ago we discussed with the minister what to do with in the drug policy, and I said that we will do whatever we have to do. We didn't have any position document, position paper. We knew what to do, and I'm very glad that we have opened this discussion once again, because we knew that when we will have to play with this data, so to speak, and now we have to finish playing with the data, and the minister is pushing us to move forward. And the information we received today from the Czech Republic are the information, or they are eye-opening information, and providing us a completely different perspective, and will have a great impact on our decision in the future, in the short time future. I mean, I understand, and I think that we also have to consider the fact that when there are so frequent changes at the positions of general directors of the ministry, it's a good thing to have a kind of a document as a guidance. And I think that in the digitalization process, we really miss such a document which would guarantee continuity. You are absolutely right. The continuity is the basis. It's great that you have survived or persisted over the periods of 9 different ministers. We had the chance to make a change, and over the last year we made great change, and we are here to do a maximum for the system, because I consider my position a service. Uh, uh, well, this is not my merit. Uh, the COVID made its own role, but at this level we didn't have any problems with the previous ministers. Adam Wojciech also did everything to get it going. And there is one more thing I wanted to say. It sounds really great, so to speak, but the core of the system, the big data house centralizing the data of all insurance companies, is actually doing the job. We have defined the system. The insurance companies get tuned on exporting data. It took some weeks. And then my team programmed the process for 5 million Czech crowns. It was my team which programmed it in-house, led by Magister Klika. And this is actually the core work. So from the IT perspective, it's just one episode which actually puts the healthcare data system to the spotlight. So you actually decided to code some programs and parts of programs to be flexible enough. This is the only way to survive. The General Director asked for the floor. Thank you. I would like to emphasize once again that this is not about that we came with a declaration or a position paper determined to change the digitalization of healthcare. These are the same issues, the same topics which are being discussed in the Czech Republic and also in other countries. But I understand the question. We have signed a range or a high number of different papers and declarations in the past. The point is not the number of changes at different positions. The point is that in the healthcare area there is a huge number of atomized solutions which are occurring. And we arrived to the situation that those who operate the data are not in the position of or do not have the ownership. They are only ensure the collection and the interoperability. And once we continue or keep this atomized system, we will never arrive to the only source of quality and reliable data. So the point is to make the step. So it's not enough to sign a paper, but to fulfill it with contents. That's why I want to emphasize that we are not here to declare that we as signatories will try to design something and to propose something. The point is to do everything for the change, for making the change. We keep talking about how much we need quality data, but at the moment we do not pay attention to, even if all the methodologies would be set correctly and the consolidated solutions would be in place, we don't know whether or not we will be able to manage it from the technical point of view. Let me give you one example. It wasn't the key service of NCZE, that was the joint project of several institutions in Slovakia. That was the report on childbirth. And this report showed us what is the real status. I was asked why we cannot provide data to third parties because they have to make some specific decisions. So this specific data, important data which we needed to get from the hospitals, but we didn't, because some hospitals send these reports or send the information in the form of reports, but other hospitals send it in data packages, CRVs, and we didn't know why there is non-compliance between the two. And when we found out that they use this very same functionality in two different systems containing inconsistent data, we started to think about how to eliminate this situation. Just imagine that this is a simple report on a childbirth, but there are tens or dozens of such reports. And this situation results in having several data sources which are not consolidated, and at the same time there are no adequate technical means to change this state. So what happens? Most of the hospitals work in online-offline regimes. In order to get the data, they have to sign in. I mean, the doctor has to sign in and to upload the data to the system. And sometimes the data are waiting for a week because the doctor might be in vacation or be busy, and the technical parameters have not been set either. Now we know the problem, we named the problem, and that's why we would like to offer a solution to data collections once the technical processes will be set correctly. So let me remind our dear audience that we have the hashtags, Slido hashtag HDV. I can see that some questions are being raised here. Unfortunately, it's time to sign the declaration, and that's why we have to close this debate. I believe and I hope that you will be available for the discussion at a later point, because I hope that we will have many questions. I don't know how much time you have, Professor, for us. Are you staying with us or? Okay, that's excellent. The professor will be available as well at a later point. And I would like to ask those distinguished signatories to gather together in the room next door. And in the next panel, we will have a very interesting information and interesting presentations on the inter-ecosystem, which will change the health data system for a long time. Thank you very much.
Ďakujem pekne, už som dokonca aj spojaznil slajdov, takže na konci ste sa aj pýtali otázky, len bohužiaľ som mi z nejakého dôvodu nevidel.
So I will answer some of the questions in the last panel for gourmets, because there will be executives. You will be able to ask very technical questions. I would like to welcome our panelists. We will start in the order as we will go. The objective of this panel is to go through the view how good data can change the system, how we provide healthcare and all functions around. Let me welcome Mrs. General Director Milka Lapuníková from Roosevelt Hospital in Banská Bystrica, General Director Mišík from the Institute for Healthcare Analysis, Mr. Marian Schott from the Association of Medical Doctors, Vice Chairman or General Director Marian Faktor from Health Insurance Company Dvovera, and Country General Manager of Medtronic, Mr. Vladimír Mičieta. After this panel, in order for you to know, we have a shorter panel with two presentations about the regulation on secondary use of data, and then the third technical one. I will thank you for staying, because these are topics for specialists, so I appreciate you are here with us. If I can start with the first question to Mirka Lapuníková. In the first presentations of Professor Dušek and Mr. Miško Štofek, we were saying that we are collecting enormous amount of data for your hospital. If you are to assess how much time daily a doctor, nurse spend by reporting data to someone, somewhere. Maybe eventually I would have to say that it's more time than with a patient. The roles are divided. So essentially, according to the process setup, how it works, non-attested doctors spend a lot of time by data processing for their older colleagues, and also report the healthcare provided for them. Our objective is to bend it a little, so to speak, and to a large extent we are trying to replace qualified workforce, that is the healthcare categories, by non-healthcare workers, and centralize activities to load the actions carried out by other people, non-healthcare. I understand. How much data do you enter or report, whether it's standard doses, is it, how much of it is duplicated? Can you estimate in hours or other units? This would be very bold on my part if I tried to evaluate this. What I could say, we worked on this, we have quite an exact analysis of all possible reports that we are sending somewhere, to be able to check if we send everything to everyone, because it's true that some data is sent in duplicity to the ministry, for example, but we are working on the information systems, and as Professor Dušek said, we are trying to go this path with our vendors, and we are talking about it intensively, that healthcare documentation shouldn't be dealt with like the doctor having the possibility to write in something, but it should be only options, and there should be some manual in the background, and all components including DRG should be dealt with separately on the background of the information system. We've been talking about this for a long time, I understand. Thank you. If I can ask one more question to the president, because on daily basis reports data, how much of the information you report gets back so that you can compare with other hospitals and you can make decisions on that basis? Almost none. I have to say that we appreciate the initiative of hospital assessment evaluation by INECO, and of the statistics, which are very valuable for us. We do receive some feedback and we can compare among hospitals. This is what we need. Without the benchmark, we cannot increase quality, not only in provision of healthcare, but also economically. And these are key. And the data doesn't have real reverse flow. Thank you for confirming, because this was one of the findings. And now the president, how much time do you think you spent reporting something which you have already reported somewhere else, or which could be automated? I know it's suggestive questions, but you are experienced debater. First of all, I would like to greet everyone. I, as a provider of outpatient care, when I came here, I said to myself, what I am doing here? There are only analysts reporting statistics. What am I doing here as a provider? I was happy seeing the Czech analysis saying that it shouldn't be done by the last links in the chain. I want to answer your question. We really spend more time with computer. I have to confirm the words of the director. We look more into the monitor than at the patient. When we try to click through something and to do something, if we take it, we report in that way some data to health insurance company or and CZI. It's at least half to 3/4 of the working time which we spend looking into the monitor, because which is a disaster, because we should be looking at the patients. We are waiting for the response. If the recipe went through, we shouldn't forget that the legislation mentions electronic recipes, even made the situation more difficult for us. If we are reporting such a quantum of information, having no feedback, and each year having to send separate statistics, and currently in 581 there was a chapter that we should be sending specially or separately. The providers, really 40% of providers are in the age of 67 plus. So we take it from the viewpoint of electronic and internet skills. I think this is a big amount of information we send and have no feedback on. And the second point I need to mention is that even if we send some data and we have to make our own initiative, some reports and recipes, or prescriptions, the feedback we would need is the feedback from hospitals that the patient was discharged. He has a discharge report. I understand it's a lengthy work. Sometimes we would welcome if it was in structured form, but from this aspect, not all actors in healthcare fulfill these obligations. I'm sorry to hear this. Theoretically, it might be a solution for reporting that you would have some assistant personnel who would do it, but there is a lack of personnel. Someone would have to pay for it, so this would be probably the worst solution, to have it at the level of individual medical offices. If I can ask Marian Factor, you as an insurance company, you have enormous data set of information. You have not only the reports defined, but some specific ones as well. Do you lack something to be able to do good decisions? Is there something lacking in order for you to be able to say if to make a contract with the provider or approve a drug? Hello, first of all, always there is always room for improvement, but the priority, the first step, it's not a problem that we wouldn't have enough data. I would say we have enough data, but to increase the extent of utilization of the data we have available. And I am extraordinarily happy in this discussion, but plus minus the same introduction. As Marian showed, I am not a fan of this topic that I would be living out of data and I would be working on data overnight or at night. I spent my time in hospital for a doctor who is with a patient daily, and for the last years this topic brought me in completely, and despite of my medical past, I say that the value of data is unimaginable. That's why I am getting to the utilization. Even if we use the potential to 5 or 10%, if we improve it by 5%, it will bring enormous value, and we are far to the 100%. I'm saying it on an example. Many of us would say, I work with Excel. But the truth is that we use it to 5 or 10%, and all the other features are unknown to us. So the data which is available needs to be utilized more and more. And one more remark in a way of introduction. Until now, many views were presented on the value of data, and I will add one more. It was in between lines, but I will try to underline it. We in Slovakia exert much energy to one topic, and that is lack of doctors and healthcare workers in our country, in the Czech Republic, in each country in Europe. And that's true. We adopt solutions, changes in legislation, support program, how to increase the number of medical students. I agree with everything, but it's just a piece of puzzle in the solution. We will not solve the lack of medical healthcare workers. We will definitely need to add innovation and work with data. That's the potential of good data, high quality data. If we can utilize it, it will solve the availability to an extent as well. Marian Schott called the microphone because he wanted to respond. I would like to follow up to Mayo Factor in this respect. The data which is very important there and which move us in a way, I would like to follow up that for us it would be very positive for all of us if we had peace for work, to collect analysis, to work with the patient, so that we have long-term vision that we want to go this direction, because currently I perceive the situation so that we keep dealing with something else every moment. We are running in circles about money, lack of personnel, but we don't have any positive stimuli how to move forward. When I saw the data from the Czech Republic, I said to myself, so look how prediction they have of information, of data, which in some way can move on and we are running in circle. What is the catalog of actions, what we make, what money we make? Current providers are out because you are not healthcare workers, but we don't have the peace for work and the data collection. We need peace for that. Any hastiness in this is counterproductive in order for the data to get collected, for the people to be willing to collect them and to report them. I understand, even if the basic premise could be theoretically, if you didn't have to report so much, if it was limited to a couple of key things, maybe there will be a greater will to report. Certainly, it would be beneficial, and it would be beneficial also if we didn't have to do it manually, but if it was automated, that something somewhere in the background. And second point, which many healthcare providers fail in, is that we are scattered over Slovakia. Whenever in Slovakia it is, we fail on the point that the infrastructure is not very fortunate. Not all of us have optical internet. There are areas which are not covered yet, and our hardware is not up to date. Somewhere they work in some Windows 97 interface. To say an example, this is a handicap we have, and the peace for work would cause, would result in, okay, I can buy a new computer because it brings some benefits. Vlado, for years we've been dealing with data from the perspective of categorization, for example. What I'm interested in, imagine now, and you can explain, if you had data you were asking for years, what would change? Would you have greater number of categorized materials, or what would be different if you had the data available? We would be able to say which of the therapies is suitable for our market as for the spectrum of patients and the problems we deal with. As Professor Dušek shown, you can have diseases in different staging, and if we have colorectal carcinoma in stage 3 or 4, late diagnosed, we cannot talk about laparoscopy surgery. And this is data we can prepare what therapies we will bring. On the other hand, we know what is the real pool of patients. On the other hand, it is not our objective as a supplier to maximize sales. On the contrary, let's offer solutions that are more efficient, that will capture the patient earlier, and we can provide targeted therapy, availability of data. We can use innovative treatment or technology, and the innovative technology, although more expensive, we can afford it. Understand? So if you had the data set available, as Professor presented, of oncological diseases, that's what you would need in order to be able to do to get there. We needed, there was some reporting of medical economic analysis. Anyway, we will have health technology assessment here, which is already implemented, in fact, and if I don't know how many patients I have in Slovakia, I cannot make relevant medical economic analysis what I am bringing and offering the market. Matej, you joined the ministry at the worst time during COVID and chaos, and I assume that only now you have come out of COVID waves. You've done some budgets, nice projects, and my question to you is, which, from your perspective, you have enormous data set, what you would be able to do it based on that, and you still don't do, where you can see the unused added value. That is my first question. And second question, what would you need to change in the sector for the data to get used, whether for pharmacoeconomy or prediction models or some better education of the society? Your first question, and I would repeat what we put here that there is really more or less enough data in Slovakia, or also the quality of data which is from health insurance companies. When we talk with colleagues from abroad, not everywhere they have interconnected data from individual fees at the level of individual patients. This data we do have. It's there then more about being able to utilize them sufficiently, and uh, we use them for automated processing as they do in the Czech Republic, and automated reporting, some things that are now done manually by healthcare providers. What would you need in order to do it? Do you have the support from the ministry? Do you need more people or some budget to get there? I think this project that is just being presented has its key objective to some pilot projects that are done in this framework have the objective of taking, for example, one report and substitute it with available data from healthcare insurance company. The quality and the motivation to report this data is high by the providers. On the other hand, they have high level of control or visibility from the perspective of the health insurance company. So the motivations are set up very well there. I would like to come back to, I think that the source of data is very good. What we need to expand is not to have, not the access shouldn't be only for the limited 9-member team on the ministry or NCZI, but let us have the data sufficiently available, accessible and utilizable, and then let's have it more the storytelling, what is in the data rather than the technical processing. What would help a lot, whether we talk about the budget or some epidemiology. When we talk about COVID in particular, one limitation of data turned out, and that is that they were coming with a couple of months delay, which mostly is not a problem, but in COVID it's useless. So some real-time nature or linking to other sources, like in Denmark, where right at the outset of the pandemics they linked it to social data and knew in which professions there are epidemics and in which areas who is risky, and the real-time management was possible, which in our country until present wasn't achieved. We have separated epidemiological system. Some data is in NCZI concerning tests or vaccinations, and this ecosystem about social data we never managed to create.
And from the budgetary point of view, advocating for some measures, data from social insurance companies would be really desirable. We saw it when planning the vaccination processes. The entire process with the social insurance company, including the sick leaves and discharging the persons from the database of sick people, etc., would be made easier. Thank you very much. So I have a couple of questions here, but I am listening carefully, and I heard and noticed one very important point you have made, and this is the data necessary for the payments. There have been a comprehensive discussion on the data which are used for calculating the expenses per patient or per diagnose. So it might have some limitations. This is actually one of the reasons of implementing this project, because we need to arrive to an agreement how to move on, because the ministry can participate in the first and the second and the third phase in order to be able to amend the current legislation. My next question is the topic which was actually addressed by the professor already, namely that some key solutions are developed in-house. And one of the failures of the system was that in 2019 the state actually failed in creating these systems on its own. And as a result, now we are in the hands of big IT companies. But this is the hypothesis, not a statement. So my question actually is whether it would be good to use in-house capacities. For example, in Košice, the former prime minister bought a company dedicated for the MCE or for the ministry. So my question is what do you think, whether it was a good decision? Well, this morning we talked to a professor, and he underlined that part of the success was a close cooperation with the academic scene and the university. This was one key to the success, and the second key was the utilization of different financial schemes, which have a great advantage that first the applicant has to justify the project in front of a special board or a jury, and I think that having certain competencies and to develop it in the light of having the data available in the system would make it beneficial to have this broader cooperation with the academic scene and the professional areas, whether it's epidemiology or prediction of different diagnoses. So in other words, just to strengthen these two aspects on both the side of the ministry and the side of NCZI would facilitate the in-house capacities of the state. I understand, and this would make the state a better partner in procuring the capacities. Miriam, what do you think when we arrive to the state that we will see the real-time data in a nice division as we would like to see? And also what are the barriers, because this is not one of the most projects. So what do you think has to change? There is a nice English word which sounds attitude, and I think attitude is the most important for this process. I think that many people who work with the system, and I hear it all the time, claim that for having data or such data we need a lot of money. So first of all, I don't think we need so much money. First of all, we need to decide that we want to do it. So we in the Slovak Republic, we have to achieve that all constitutional healthcare providers are hospitals, which I consider a great success. Moreover, we have commissions working within the DRG system, increasing the quality of inputs, but yet there is room for improvement. Nevertheless, I have to say that the ministry is working really intensively to develop further the DRG, but there is a lack of staff. There are persons like Angelika Salajova, there is only a few persons like Angelika, and this such a comprehensive issue cannot just be the scope of one person's work. Should she have three more colleagues who would drive the economic parts of this project, in 2 or 3 years' time, we might have high-quality economic data, which are of key importance. And the DRG, which actually exists in Slovakia, will have its really real weight recalculated from January. So it means that you have selected those 14 something hospitals which will serve as a basis for the calculations which start from what exactly? Could you please specify what do you mean by? In principle, I have checked the schedule for the medical association, and there was a bullet point saying that starting from January 1st, 24, there will be a prospective budget introduced, and formerly used weights of calculation will be eliminated. It depends. I can only answer on from my own position. Canceling this weighting system would not be reasonable. There are several ways we could take, for example, using diagnosis based upon DRG, so the system of reporting and the financing system. So the reporting is out of question, the reporting is a must. But when it comes to the mechanism or a system of payments, I think we have no problem of using the payment systems based on the DRGs. Thank you. The historically weakest data the ministry has are associated with the outpatient care facilities. What is the situation there? So we are modeling, so we model a kind of sample outpatient clinic or ambulance. And the next challenge is that we receive annual reports which are processed. In institutional care, it's okay because except from one hospital, all the other hospitals provide such reports. There are still some additional reports to the chamber, etc. So we have to monitor also these parts when preparing the budget, so we don't forget of several thousand doctors. So these data are used for the purpose of budgeting. My next question goes to Mr. Shaw, because one of the standard methods the ministry is using, namely why they don't want to improve or increase the number of specialists. So actually they have designed their own models, and all that was decreased by 30%, and a lot of miscommunication arose from that. So can this data be just driven from insurance companies, or will those balance sheet data have to be uploaded, because that would be really time consuming. So if you see such a report that's something really difficult and complicated, it has several dozens of pages. So what do you need? Do you need motivation, or do you need stimul in order to start dealing with this? We talked about prescriptions. There was some symbolic payment of 0.002 euro cents, but it had some impact. That's why I'm asking. Well, I really appreciate all the providers of ambulance care because they all started doing these reports even though we didn't have the resources, because they believe that if we will have this electronic prescription system, the quality will be higher than the simple or traditional paper-based prescription. Our goal is to say clearly or define clearly what do we actually want from the outpatient care providers. And also it has to be friendly for the provider. And what the director of Roosevelt Hospital said made me smile, because the greatest problem is that many times this work is done by the healthcare provider. The doctors should primarily take care of the patients, and this is my professional as well as private experience, that I am not interested, I don't want to do that because that's not my priority goal. That means that the provider should be relieved from this burden, and we should provide them a different alternative, maybe something which was in that circle, the scheme, in the center of the circle. We should find a space or a field for somebody who would collect the data, because quite frankly, some of us are quite skilled and can use IT. Some of the doctors have some family members who are good with or experienced with computers. And in case somebody who is good with IT technologies would be reporting, the data would be clear and more precise. So I remember in the past that I was the one filling out or uploading the data to NCZI. For example, the pediatrician adding up all the diagnoses, and the figures did not match because he was calculating or counting the diagnosis physically, and then his data collected physically in the praxis and the data in the system were not matching. So it was not possible. So because they were adding apples and pears, and the result was not reliable. So the form has to be clear and simple, because as soon as a medical professional is expected to provide the data, it will be misleading. Thank you. I have a couple of final questions. I will start with Marian Factor. You, as an insurance company, what is your data strategy, or what is your vision? What would you like to achieve in terms of data systems or inputs for analytics? Do you have any idea, or do you have this topic on the list of your priorities? Well, there is an initial discussion going on how to proceed. This discussion started 4 or 5 years ago, and based on this debate, we certainly assigned a team which is called Data Allocation Center. It includes data engineers, professionals on AI, and we arrived to the conclusion that it is not possible to adopt any strategic decision without data analysis, because in this case we would have to in a 6 months time get back to a certain decision and check whether it was correct or not. So when, for example, if we offer the clients phone consultations 24/7, then we need to follow and monitor how many calls we will have and what will be the trend. For example, if we introduce a new position of an educator, who will not be a doctor, but somebody who will be available to answer questions. For example, if somebody would like to know why the private insurance company is spending money on introducing new job position, we made relevant calculations and we arrived to the conclusion that it's worth opening such a position. And also on the national level, to ask or to push, I don't know which word is the most adequate, to have data analysis, and each and every key level decision has to be supported by data. And we who are on the other side, other end of this story, we can see that, or we want to see that the responsible people should be bound by the recommended solutions. And what is the most important in terms of the future, I'd like to reinforce that in our case it's not the lack of data. Yet I understand that somebody might claim that, but sharing data or the quality of data. Somebody might say that I'm going to use or utilize data only if they will have a certain quality. It's not the case. I think that utilization, we actually already use AI technologies to analyze and to identify or determine some behavior models, and the question is why? Because uh, it made a significant change. In particular, that there are changes by regions, by days, and the using or utilizing AI could unify the data, ensure unification. And for the future, as far as the future is concerned, we would like to improve or increase the utilization of data.
Predictive models, it's not a problem. There are examples from abroad. We are not reinventing the wheel. We always look what is working abroad and we try to localize it in Slovakia. For example, the case management, we are able to identify a patient who within 6 months will be very expensive, and we want to intervene and influence his health conditions. We have predictive models which can with high probability say that this patient will need total hip replacement within 12 months based on some healthcare analysis in the last 6 years. There is some sequence of episodes from the healthcare. If it occurs, there is a high probability that the patients will need the hip replacement, and this is often an information that we know earlier than the patient and his orthopedist. I may add that I'm not the father of these data. It's Ivan Popradsky, our former colleague, and the first person who established the institute, who is not with us today, but he need to be merited for one thing, that he included in the law that the ministry had all copies of the reports on which we are working now. And the last question to Vlado Michieta. Now we are talking about what the providers have and what is the added data of the value they have, and you said what we could have if we had something else. And now you as a representative of Metronics, how can you help in order for us to have the better added value? Basically, we can provide, we can link some technologies which can online show the health condition of the patient. We can more efficiently set up the care, and the care then can be um, provided. We can see the patient before an episode occurs. For example, atrial fibrillation. We can hospitalize them, and he won't go to the intensive care unit. And thanks to artificial intelligence, it can select the patients and advise on serious worsening of the health conditions. That's just an example. And in fact, all solutions need to be based on the therapeutical ways. The solution you've mentioned is maybe a little more complex. It's an innovation. It's already available in Slovakia. The point just is we can have a look to the Czech Republic. Today already providers have the service available, but again, it's on the doctor who in private time have to look at the notifications from the system and needs to contact the patient. If he happens to forget, he is subject to forensic risk. There is a national center in the Czech Republic which collects the information. There is a healthcare trained worker who evaluates the notification. The notification goes to the treating physician, and follow-up is done. Our healthcare workers are overloaded by these things. If the state can contribute to how to make the work of healthcare professionals easier, it is that these technologies that can already help need to be used as soon as possible in order for us to be able to make the life of the doctors easier. I'm happy about one thing that Lukáš presented concerning the, correct me if I'm wrong, Healthcare Innovation Center. That should serve such ideas being objectively evaluated and implemented if there is room for them, thanks to data, improving the condition of the patient. How do we summarize? Because the time is up. We have heard all the points we needed to hear. We don't lose the value of data. There is room for working better on the existing data. We need the personal capacities, better competence, whether by the ministry or the state, to be able to communicate the advanced digitized topics. One topic that hasn't been mentioned is the legislation and regulation which binds our hands. And I am happy that in the following panel, which will be two presentations also, we will hear that there is an imminent regulation on secondary use of data, which we perceive that the problems the data cannot be moved on should, to a large extent, we will learn soon, improve, and what Mr. Schott mentioned and Michieta mentioned should be markedly better. So I firmly believe that when we hear it, we will have some more optimistic view that with time the things will move forward like artists. I would like to close this panel and ask for a round of applause for our panelists, Miriam Lapuníková, Martin Bišik, Marian Schott, and Marian Faktor, and Vladimír Michieta. And we can go on to the next panel, which will be focused on, you can sit down, thank you very much, which will be focused on the upcoming European and data health. Not to make a mistake, European health data space, and that's a regulation which the European Commission is preparing, and we have two presentations that will make us acquainted with it. Initially, I will ask Mr. Martin Dorazil to digitally connect, who work at the Commission in DG Sante, and his team is in charge of this regulation, and I would like to welcome Mrs. Zuzana Hečko from Allen and Overy, who is an expert in legislation and law and was supervising the legislative questions or issues. Mrs. Hečko will also have a presentation, but I expect Mr. Dorazil to start, who will describe what the regulation is about and what the consequences will be, because most of you doesn't follow the European topics, but on our behalf this is an enormous light or sun of hope which will make our life much nicer. So we will ask to connect Mr. Dorazil. If we can hear each other, you can share your screen, launch the presentation, and you have the floor. Hello, thank you for the invitation. I hope you can hear me and that the presentation can be seen. Excellent. Thank you very much for the invitation. I got instruction to be brief, so I will try to briefly summarize the proposal of the Commission for the European health data space. In the Czech Republic, a EHDS already is used in the Czech Republic, so I will use it in the presentation. There are some English words in my presentation because I didn't find a suitable Czech equivalent, so I hope you don't mind and I may explain it if necessary. What is European health data space and why the Commission comes with it right now? It's part of the long-term strategy and it's a planned project already in 2020, and I want to emphasize it was at the beginning of 2020, before the COVID pandemics, or at its very beginning, where the Commission published its data strategy. So it's a framework document in which it announced plans to create European data spaces in different sectors of the economy, and one of them was healthcare and European health data space. And in healthcare, this is currently the data space that is developing the fastest. So this May, we already adopted a draft regulation on the European health data space, which is currently being discussed by the European Parliament and the Council of Europe. And it's part of the planned strategy, but COVID significantly contributed, sped it up. I don't have to emphasize how important data was with respect to COVID. I want to mention one specific example. European digital certificate, COVID certificate, which is a very good example of how things may get moving and can result in a very specific result in a very short time. When 27 member states work efficiently and jointly, the European COVID certificate was established on the Brussels context very quickly and became a global standard which is followed by other countries outside Europe, and it is EU is becoming global leader in this area. This is an example we would like to follow, also working on the European data space, and we hope that the cooperation with the member states will be equally efficient. I will now skip a couple of slides in order to speed up the presentation, but I will stop at this one. The regulation that was passed, or the draft regulation that was passed May this year, has three basic objectives. The first is to improve access of citizens to their health data and to improve the control of the citizens over their health data. The second objective is to create a single market for the area of digital healthcare services and products, and specifically to harmonize requirements for electronic health records in order for their producers not to be subject to different requirements of different states or different standards, to harmonize these requirements. That's the second objective of this regulation. And the third area, which will be most interesting for today's topic, is the creation of a new framework at the European level to use health data, or for their secondary use, for research, health innovation, and for decision making by public authorities and institutions in public health, or for decision making of health regulators. I will skip another couple of slides, and the draft, which was passed in May, in fact has two basic pillars. The first concerns the use of health data for the provision of healthcare services. That is, the use of data for the provision of healthcare services to individual citizens. That is primary use of data. And the second pillar, and I will talk about it more extensively, is the secondary use of healthcare data for secondary purposes such as research, healthcare innovation, or decision-making and decision-making processes of regulators or authorities in the area of public health. This slide can be skipped. This concerns primary use of data. Currently, it is fully operational, the platform for cross-border exchange of some types of healthcare data for primary purposes. There are summaries of electronic patient documentation, and the platform supports exchange of electronic prescriptions. And 11 states of the European Union is on this platform, is connected, and we expect other countries to connect by 2025. We hope it will be all, or at least an overwhelming majority of member states. I will focus more on the area of secondary use of health data, and I will start by this slide. In fact, the problem we are trying to solve is the complicated access that have researchers, research centers, innovators, public institutions, if they need access to certain types of data, and they faced a question: what data is even in existence or available for their project? And the draft will help them by setting up a catalog of data sets at the level of each member state, for which a new authority will be responsible, Health Data Access Body, which will or should be established in each member state, and this will provide access to this catalog. The catalog will not contain true health data, only metadata, which will enable the users, the researchers, innovators, and public institutions to identify data sets which are relevant for their need, for their purpose or project, and later they will be able to ask for access to this data. This slide will serve to show you how, according to the draft, the pathway of the user should look like. At the beginning, the first question the user will ask: what health data is available or in existence? At the point where they identify the data or data sets which they need for their project, the next step is filing an application for access to this data. If their national authority for access to data, they will receive an answer if they can use this data. This Health Data Access Body will consider if the purpose for which this data should be used and processed is legitimate, and if it's in harmony with the European Health Data Space regulation, and if there is any suspicion that the data should be used for a purpose that is prohibited, for example, for uh, dangerous product production or for private insurance purposes or increasing payments to individual participants of the market, if a private insurance company asks for access to data for this purpose, it won't be provided. If the conclusion is that the application concerns legitimate purposes and the user fulfills all legal requirements, the body will issue the permit and data will start being prepared for the use and for provision to the user. And the data will be provided to the user in a secured environment. And that will be the responsibility of the national body. The user will obtain access to this data in this secured environment, which is where they will be able to process the data, use their algorithms or do any operations on the data, and from this secured environment they can download the results of the operations, but never they will be able to download the data itself. It will remain in the environment so that they are secure, and after some time they will be deleted. So in this way the security of the data will be provided, but at the same time it will be the users, the researchers, the innovators and public institutions will be enabled to easier and faster get to data they need.
So here I skipped one point, and here we can see the user analyzing and securing the data in this environment. And finally, the final step is the publishing of the data. All the data have to be published within a certain time period, and the data has to be, and the results have to be verifiable. So, as I have mentioned already, the proposal was adopted in May. Currently, it is in the process of commenting at the Council and European Union's institutions. This process is going to be quite difficult. At present, it's quite difficult to say when it will be completed. There is no specific deadline defined. Some proposals are adopted in a shorter time, some take longer. It may even be several months or a year, but yet we hope that this process will be as short as possible, and the final adoption by the Parliament and the Council will happen as soon as possible. And within 12 months' time, the regulation should be valid. There are also some additional conditions. For example, the secondary utilization of data. According to our proposal, this secondary utilization of data will enter into force 12 months after the adoption of the proposal. So we are getting ready now for the practical implementation of the regulation, supported by the European financial mechanisms. We currently implement the joint action of 25 countries, preparing the technical implementation of this regulation to the European space. More information you can find on the link you can see on the slide. Unfortunately, Slovakia is not participating in this joint action, but I believe that at least informally Slovakia will have a chance to follow and observe the process and join the final outputs of this process. There is another financial program in for health. Within this program, we provide the EU member states additional. We can receive additional grants. The call we expect to be published in this year, by the end of the year. And these finances can be used for the practical implementation of this. And finally, I would like to mention the pilot project, which is now being launched. And a small group of 8 countries, in cooperation with some European agencies, will start testing of this system. The data, cross-border data connection, or data sharing and utilization. And later on, in a later phase, this will be extended to up to 14 countries. I think that I exhausted my time, so I would like to conclude my speech at this point. Thank you for your attention. Thank you very much. I had one question prepared, which you actually partially answered. So what will be the consequences of this to Slovakia, especially in the practical life? But you just mentioned that we have not, I mean, Slovakia was not involved in this pilot project. However, do you happen to have any information, any knowledge about what's going on, whether some legislative changes are being prepared, or whether we are not actively participating since we are not in the pilot? Thank you for your question concerning the national legislation and its stage of preparation. I cannot give you any information because I don't have any. Concerning the Slovakia's supporting role, 8 countries participated in the pilot. This is a smaller group. Slovakia is not involved, but then there is a larger group containing 25 countries, and their role is to agree upon the technical measures and rules and principles, because now I don't have time to address each technical detail, but unfortunately Slovakia is not participating either. So does it mean that 25 out of the 27? Well, there is also Norway. I think it's 25 EU member states plus 4 or 5 countries outside EU. Also, I'm sorry to hear that. I wanted to know that because this is one of the most important data package which is expected to arrive to Slovakia in the near future, and it looks like we are not going to be prepared. I wouldn't like to see us doing every preparative activities on the very last second. And also the utilization of secondary data. If we miss to catch this train, we are going to lose years. So we are aware of this deficit or failure, and we hope that the ministry will do everything to get it right and go with the project. So my next guest, Mrs. Hedgko, will. Well, I will just shorten it a little bit because we are out of time. Okay, just I am not going to talk about the COVID pandemic. We all know that it highlighted the need for electronic data in terms of creating different policies or responding to the situation. The electronic data are important, and not only in the context of the COVID, their utilization is much broader. As Martin mentioned, the EHDS is a really comprehensive document that could be compared to GDPR. And for us, the most important is the second part, which focuses on the secondary utilization of health data. In other words, how the European citizens can look for their own data, and also research institutes, how they can get hold of such data. And in particular, the secondary use of medical data by uh, public authorities or private researchers for the purposes of research, innovations, personalized medicines is an important point. So really briefly, what is the scope of this EHDS? I believe that you have a short information on your tables, which we distributed at the beginning of the event. So you have this information available in writing. So I will just quickly introduce some basic utilization points. So the purposes are really quite numerous. Martin already mentioned that there are some purposes which are forbidden. For example, it is not allowed to request health data of individuals for the purposes of marketing and promotion. So you can go through the purposes, and if you meet any of the purposes, you are not allowed to download the data to your systems. You can only have the access or the right to view them. The data are provided primarily in anonymous format. However, this regulation specifically stipulates that in some situations this aggregated data will not be sufficient to fulfill the purposes which have been defined within the regulation. And in this case, and in my view, this is the greatest added value of this regulation, because in this situation you will have the right to request the data in the pseudonymized form, or in other words, coded. Pseudonymized or coded data are basically personal data. It is not the goal of my presentation to define what does it mean, but basically it's a specific form of securing the data, but yet these data are not anonymous, so they are considered to be private data. And many of you might think that, oh my God, how we will protect these data if they are private and how they are regulated to be safe. So this proposed regulation says that if there is a requirement of giving a consent, this is considered a private data. So basically this regulation is going to be harmonized with GDPR in terms of harmonizing the data. As Martin mentioned already, the national preparation for the implementation of EHDS will take several years. We have discussed with my colleagues how much they how much this preparation should take, and the answer was 3 to 5 years. And the preliminary preparation is estimated to last 12 months. This is not such a long time to get ready. What happens if Slovakia will not be ready on time? Some issues have already been opened. So before this regulation is adopted, we cannot say now when this will happen. We have to rely on info requests. Let me ask you, which of you have a positive experience with info requests? Which of you have a negative experience with providing information requests? It seems like the second, the later was more numerous. So before we have this system in place, the requesting parties have to follow the law, and I have selected some practical examples. This is from the regional police authority in Bratislava to illustrate how this system works or doesn't work, and to illustrate what system we have to match when requesting health information. So this request was anonymous, requested by a person who the request was rejected because the requester could find out who the person is, and then we asked another person who was not the notifying, and the authority provided the very same information. So you can see that they are using just template answers to this kind of requests. And this is all at this point. I was asked to conclude my presentation in a positive note. So I think that I ended it with the most negative information about this policy template form. Thank you. And my question to Susanna is that when is it going to improve? Well, I think the situation will improve with the introduction of this regulation, because then we will have all the tools available, and the regulation as such is determining the entire process of data request really comprehensively and in a detailed manner. So I think this is a really good legal regulation, and we have to hope that it will be adopted as soon as possible, because the research centers need it very much. Well, let's hope so. When I checked the data, we have 5 years. Is it so? Well, this is what Martin said from his practical experience, that this is the time needed for the preparation. Because we have to understand that even if the regulation would enter into force tomorrow, Slovakia is not ready for its implementation or utilization. So the point is that this time is necessary for the countries to prepare for its adoption. I see. So in 5 years' time, we will probably have this pseudonymized data, and we will know what can be provided, what data cannot be provided. That's right, because the research institutes have the right to get the data as soon as the regulation enters into force. Well, and do we have a definition of what the research center is? Of course we do, but this is a kind of broad definition. It doesn't have to be an institution in its real sense. It may even be an individual. Well, I am asking because once this topic was issue of a heated discussion with the ministry and other entities. For example, I myself couldn't find myself in the package of data, and the definition as it is defined today doesn't allow us to do anything more complex outwards. So I believe that this will resolved and the situation will be more transparent. Uh, let's take a look at the Slido. We received two questions, at least 2 out of 20. The first question came from Luboš. Luboš is asking whether there is any room for open data within the EHDS. So whether there are any standardized data sets defined which can be or will be published without a special request. I don't know if Martin is here and whether Martin can hear us. Yes, there is an article on that. However, when we talk about non-personal data, I mean that there is no personal data or personal information within the data, there is a requirement to be published without any restrictions. Thank you. I was interested to know that as well because, for example, let's take the Eurostat data. There is a database, or is it going to be a database accessible to anybody and users can scroll data in it? So thank you very much for this.
And we have another question. What will be the possibility, and we don't probably have the answer yet, the possibility of examining a refusal if a national center of healthcare information rejects an application. So define this process. If the national authority rejects the application, who will be the appeal authority? I think it's not there. We will have to provide for this process nationally. Do you remember? Exactly. There is no specific appeal. The regulation lays down that each member state have to ensure that the decisions can be examinable, but it will depend on the national provisions. I think there will be some appeal to NCZI, then to Ministry of Health and the administrative action then. We will have to move on, but this was enormously important, and I am very happy that we heard it all, because this regulation will undoubtedly define the entire ecosystem of data and data collection and data provision. Especially, I am very thankful to Zuzka and Pavel for being with us and presenting this. Thank you again. And we can move to the last panel, and that's the panel, I will ask the panelists, where we go through, let's call the more technical or more detailed third phase or key conclusions of our common project. I will ask the colleagues to come to the stage so that I can introduce them. We have a couple of slides ready if they want to use them concerning the oncological registry and the data hub through which, with respect to the new regulation, we could very efficiently publish this data and make them accessible. If I may ask you, take your seats. Mishka chronically doesn't like to speak in front of an audience. She prefers Slido. I will go in order. Miška Laktišová, who you will know from the ministerial career, she drove the project because this is a matter of her heart. Jano Tomášik, IT expert, who was doing the part of how the system could work in the data hub phase. Martina Naďová, director of the National Center of Healthcare Information. I cannot translate it correctly. Director of Division of Health Information and Service and CZI. And Martina Rafajová, who is in charge of the register. You have a couple of slides. Do you want to show them? The objective is for the audience nicer explanation of the key proposals or how we think we could change the oncological register and how the data space could work. And I will leave it up to you. Who would like to start? Ladies told me to start. I have slides ready, but in fact a lot of what was already said is there. They just summarize the points, what needs to be done, and the presentation that we were preparing, what specific steps should be taken, also what was mentioned recently, the European regulations that are in preparation. One of the important points or steps in the action plan, we somehow agreed that we needed some data governance framework which will tell us how to do it in Slovakia. It shouldn't be a 1,000 pages book in which someone would be writing for 3 years, but some action rules as presented from the European plan, that there was some 7-8 steps. What is done, who is doing it, who is responsible, and if some decision is taken, so that the consumer of data who needs data for some purpose, so that they get it and can be able to work with them. Those were the slides. And what is important, what colleague mentioned, since I worked with different databases historically, we do have the data in Slovakia. Many data we have online. The national electronic system receives million pieces of data on daily basis. What I was inspired by recently, when we were charged with starting the system, when doctors were asking at a conference how you helped us, what we should do to help the doctors since they help us as patients. And maybe the second point from the bottom says what the previous speaker said. We are asking for more data than we return to the field. We do not return the value which is stored in a safe into which no one can get. 400 pages report is a super thing, but what to do with it? Since doctors told me, I keep asking how we help them. And these are things we should say to ourselves, the rules, and to define what we are going to do. In addition to having some clear action plan, and I hope the memorandum or the agreement that was signed today could be first step to introduce the continuity, to avoid changing it every year. What experts agree that what needs to be done, as Mr. Dušek said, it needs to be done simply. It's not that we don't know what to be done, but we need to start doing it. As Marian Factor said, let's use data for decision making, but then measure how it helped, if the results were achieved, the KPI. In any commercial world, when they are going to invest millions, they always measure if it happened. The steps, something of the things that are necessary to happen already happened, but enormous piece of work is ahead of us, to get ready for what Europe will order us to do. I would like to emphasize a lot of it is already invented. We should start already available data. We shouldn't be building enormous super system that will know everything from the first day, but let's pick the priority things also from other fields, how systems should be developed. The development is reoriented to first finding the need, what we are going to do the system for, and who needs the data. In the previous presentation, it was mentioned that the doctor spends a lot of time by clicking data, 55% data of time. That's very bad. The object of attention should be the citizen. Other statistics say that there is 34% of error in the data, that in fact it's not true what is in the data. So the analysis, and my colleagues may correct me or add to it, even if we eliminate 20-30% from the existing report, I believe nothing would happen. The quality of what we can get out of it will remain, but the doctors will not have to click so much. I am in favor of structured collection. What is left? Let's collect it in structured way. Let's collect less, but at a higher quality. This summarizes the roles which should be involved from any theory when it's always some business requirement, which in this case is represented by the Ministry of Health. Then there is some guarantor who, in case of Slovakia NCZI, and then there are consumers or customers. In any other context, it would be similar. What we need to do is the center, the sweet spot, what we can technically implement, what the regulations require, and what consumers want. This is the thing that these subjects should be solving together, because none of the stakeholders can achieve it on themselves. And the place where the data should appear, it's no rocket carrier, it's the methodologies how to build a hub to collect data and provide it to the authorized persons or eligible persons. We just call it data hub. It should provide also unstructured data, but those who need to get there should be able to get there. The problem we don't have is that we already collect data. There is no problem with it. We sometimes collect it unnecessarily. That's a problem. And the quality is not as bad, even if we could clean it up, but super clean data will not ever be available in our lifetimes. But let's concentrate on what we have and let's dig data out of it. Excel was mentioned here. Excel as the best information system in the world. Anything can be done in it. But in other countries, there is not a solution that can be simply copied. It will be much up to us in Slovakia to start building the national solution, to get inspired what is already in existence, not reinvent the wheel, but take some methodologies and support all activities that were mentioned. As for the steps, if we want, and in a couple of years we will have to have such storage, this is a summary of the steps that are necessary to move forward, to select the set of data from the data available, which is needed by the consumers, which is the priority thing that can be already provided. This is what you, Martin, asked about. We need to know that there is one spot when we log in, we can get to the data. When I am a person I need to be able to know that I can get to data for my analysis. And if it is a ministry that needs to do some decision making or a specific institution in the state, they should have the single point, because now the data is in different databases, they are scattered, difficult to link. And what is happening in the Czech Republic, they want to link healthcare and social data. That's exactly the data hub where it should meet on the basis of some identifiers. This is probably all on this topic. Maybe even before that, if I can ask, when in reality you can imagine a doctor in an office, when the doctor would have fewer reports to enter data in, when the doctor will feel it. Today the declaration was signed. Uh, when do you think this could be implemented? My opinion, if we apply the outputs of the analysis phase 2, there are candidates for deletion. We delete it and nothing happens. That's the help to the doctor. In the existing reports, there is a set of data we can replace by data from healthcare insurance companies. Uh, Statistically, it's a very important set where it can be corrected. We don't need to have 100% version of truth for some decisions. But on the other hand, the clinical data which are in the remaining reports after deletions and modifications would be made more brief. There was an ambition to cancel some reports altogether. And when Dr. Schott mentioned that manually they add it up and then it doesn't fit, I could see it, how it happens in hospital, paper, pencil, and yet it is in the data that goes to the health insurance company. We do it unnecessarily. So the process will be several steps, but the first step, when could it be implemented? Mishka whispered immediately. Yes, immediately. The deletion immediately, and in order to get it to some one place, it's not a technological problem that we wouldn't be able to move the data. We are talking about the horizon of half a year or 9 months. We went through this before the conference. There are steps that simply can be done, but we need to start doing them. We are not too far from it. Let's say within a year and a day, I think lots of what is on the slide is realistic to expect to happen within a year and a day. As a true politician. Okay, we are joking, but we know that the process has some steps. Martin, what do you think? When, Martina, when it will be done? You were at different projects where we were trying to change some things. You have a greater track record in this. Will it be possible to abbreviate, automate some of the reports within a year and a day? So what is your perception? Thank you, and thank you for inviting me as well. Yes, we will dealing with this and still deal with it. I personally think that this project, health data value, gives us space, and I'm very happy about it, to deal with experts and expert companies and the Ministry of Health, to deal with the question of individual structures in health, in data collections. I may be very detailed, but I apologize, but it's very important at this point. We have a space here now to go through all reports, collections, registers, and to say in reality, realistically, at expert level, what we collect, what is necessary to be collected, and to identify data structures which we don't need, and to identify data structures which we do need, and where, from what additional sources we can look for them. At that point, we will be able to say, yes, we have, say, 40 annual reports, which are statistical reports, and we can automate some structures, we can calculate some structures, we can use different sources which we have in the database. We can link it based on identifiers, and we can get to a condition where eventually we will really cancel some reports. And I don't see it like we sit down tomorrow and say we don't need these reports, because it's not a matter of one or two people who need these reports. We are talking about an international institution, etc. That's why this project is here, and I welcome it that we can take a comprehensive look. But what I would like to point out is one important thing. I very much understand that a doctor first of all should examine patients, but I remember when I was a kid, when I came to a doctor, the doctor was writing everything on a piece of paper. My health record has 3 centimeters thickness, so it's no new thing. The doctor always had to write down the important points of the examination, and now in the 21st century it's time to write it down into the electronic system. We did we need to have the structures, and we need to talk to the expert who will give and program the structures, so that as for our reports and reports, most of it it's so that they don't need to use paper at all. They have electronic forms. The vendors can do XML uploads for them, and web interfaces and web services. Whatever they write in their system, they don't need to know what systems it is uploaded to, whether it is uploaded to healthcare statistics or e-health. So today already the technology is available, but it's not accepted and it's not used by healthcare providers. And now I will follow up. Even I can have additional question. There is a continuum. It can be done immediately, year and day, and you see it longer. Uh, I can see this as a subject of our analysis, and this is how we will proceed. As we started with NOR, and we will continue with reports to national registers and under other implementing regulations, and in cooperation with expert public we will say what is necessary and what is not. If there is data which realistically on the output as indicators and different anonymized data is not necessary, then it's not necessary to collect them. On the output you can have what is collected. If it's not collected, we cannot expect it on the output.
Well, Michal Stovko asked for the floor. Yes, that's right. I want to add one point. Today it's important to analyze data which we will have to collect. Then we need to know which data we need to provide. And the third point is the NOR. We have such obsolete data that this NOR is absolutely not up to date. It cannot be used for anything in the practice. Professor Duszek had a really interesting idea, saying that the only way how to start the NOR is to jump through or to automatize all the data which have been collected over the last 10 years. There is a huge number of diagnoses and screenings, not to mention the oncological ones. So I would really suggest to do some things quickly and more precisely, and stop thinking about how to process the data over the last 10 years, because something we cannot do retrospectively. So the audience appreciated this position with an applause. So there is another issue which is the subject of our panel, which Miško actually introduced by his comment. Well, so let me continue my speech. Within this project, we selected as a pilot registry the National Oncology Register. As our colleague Mr. Dušek mentioned, we decided for the National Oncology Register because this is an important issue, and perhaps this is an area when there is the most problems. And as mentioned by Professor Dušek, the situation is diplomatically said sad. So now we are closing or completing the 2014 year. So we decided to review all the processes, all the reports, the collection, the processing of data. So each and every activity used to fill up data to the National Oncology Register and to define and identify all the related problems. We decided not to close our eyes from problems. The data are there available until 2014 with a time delay. As far as the quality of data is concerned, these are the highest quality data on the European level or global level, so the quality is really good. What is missing is the level of filling. So as I have mentioned earlier, if we don't have data, we cannot expect outputs. So we do have the data available, but 80% of the data are on paper. So some facilities really neglect their reporting responsibilities or duties. Many times they are waiting for us to request data for 2014 to 16. Sometimes they are sending us non-structured reports and reports which are filled in manually, and this results in us providing more manual work in terms of reprocessing the provided forms, re-evaluating some data, recoding some issues like the number of hospitalizations, the reasons of hospitalizations, and mortality cases. And we arrived to the conclusion that this work is not sufficient because it does not allow us to meet the criteria of the European regulation, because we are working in a non-adequate environment. So we identified the requirement to have all the data on the same technological platform, and that does not only relate to NOR, but any data we are collecting. So only this way we will be able to integrate the data and fulfill the requirements of the European regulation, and to provide them either in anonymized or grouped form. So this way we proceeded and tried to identify the bottlenecks of the process. And we tried to identify what we can do on the end of healthcare workers. We discovered that the personnel is not sufficient, and at the end of the day, the user is suffering. And we are also suffering because we are not able to meet the requirements of the public. It's important to not only to name the problem, but to find real solutions. Concerning the NOR, we have planned to use this famous quote that once is enough, and we decided to simplify the process of providing data to our database. So we reviewed the 4 report forms we currently use in cooperation with experts, and I want to express our gratitude to the experts, because together with the American Chamber of Commerce and other experts, we optimized these reporting forms in question, and the data structure within the form was minimized, which doesn't, of course, mean that some data will be missing. The point was that now we can identify where the data come from, because once they are reported by the doctor, they must match the place in the database where similar data are being stored. So that was a close cooperation with experts, and we also cooperate with the Authority for Surveillance and the Statistical Bureau. So basically, the point is to be able to integrate the data to fill the medical record of the patients. And let me emphasize that the basic is to provide upload data to eHealth. And if we want to extend the scope of data in the sense of this reporting to NOR. And finally, I want to mention that we are not going to only deal with NOR, but all medical reports, but this is the key point. In the next step, I have mentioned that we have already finalized the reporting forms. Now we expect that as of January 1st, 2023, there will be a possibility to fill in these forms. Let me remind that these are not papers. This is not paperwork, because extensive paperwork is a path to the grave. Within our legislation, we will prepare the forms, the methodologies, we will communicate with the reporting units, explain and teach them how to proceed to be able to launch the new structure on January 1st. We are also working on the possibility to use other sources to fill in missing data. And I lost my thread of thoughts. Well, communication. In terms of communication, we need to agree with the ministry to provide some kind of education or explanation of what to do to get the required data. Some might ask what are you going to do with the previous years? Well, there were some suggestions to forget about the past data and concentrate on the current and future data. I don't quite agree with this option. We assume that this development, which is closely connected to the data hub, when this will be put in operation, we will also see the cases from the period of 2015 to 2020. So we will suddenly be able to see what we actually received electronically in the period of 2015 to 2020. And based on those data, we will be able to compile some incidence cases. We will have to review those data, but definitely if this reporting unit would utilize the technical possibilities given by the system and send us reports electronically, not in a paper form, we will be able to uh, to use the data from 2015 to 2020 uh, in an automatic way. Well, if we can go on, I have a question to Mishka. What has been presented now, I mean the milestones of NOR, and those who know you, they know that you are the greatest jihadist of this project. When Professor Scholti also raised this issue, well, it is not enough to say that making something electronical doesn't equal to digitalization. Because if the doctor fills in a form on paper or on the screen, it's a big difference. We should minimize the time spent by filling up forms. You mentioned our former director, Mr. Pokrotsky, and during his office we managed to launch sending data from constitutional care to insurance companies. Actually, he wanted to have those data on the next day, but we managed to get them within a year. We have prepared a methodological guidelines for the data in the DRG structure. The time goes on, and the constitutional or institutional care doesn't meet the methodological guidelines of providing institutional care. I don't know why we didn't manage to extend these data in 2018. So what happened to me is today we are in 2020 and I cannot see any progress. Well, and the director showed a slide relating to the progress, anticipated progress in the future. Would you like to comment on it? Unfortunately, I don't see it on my paper. Could we ask the technicians to project this slide? Just a second, we should be seeing it. Yes, we have it now. So just briefly, this slide, I have explained it already. At the beginning, there is the revision of the reporting forms, revision or reduction in terms of scope and length. We assume that these forms will be by October 31st completed and distributed to the reporting units in order to be functional in 2023. At the same time, as my colleague mentioned, we are planning an extension of the medical benefits or allowances depending on DRGs. So we plan to introduce this new functionality at the beginning of the next year. It means that the allowances should include the DRGs. It means that most of these problems Mishka raised will be resolved in January. Well, we had this ready, but then COVID happened, which actually halted this process. And when we were able to continue, new questions arose. So basically, we continue this work and we plan to have it introduced in the first quarter of the next year, including the cooperation with insurance companies and NOR. And we want to have this new reporting form. And also, in cooperation with the ministry, we want to start or enter into talks with professional fair, and also launch education as to what we do and why we do it in cooperation with NOR, and it includes all the reports. And last but not least, we want to focus, or we have to focus on Data Hub, because we have great expectations from Data Hub. As a priority, we expect that we will we want to provide access to a broad range of users to specific data, uh, anonymized. We will have a year or two for that. It will depend on when the legislation, the respective legislation, will enter into effect. And as soon as the respective act will enter into force, that will be a key point for us. And I will keep emphasizing that the basic is that all doctors who have to upload data to e-health have to do that. Okay, I can see Mishka. We have heard from Lukáš Palaj that data from eHealth cannot be used at all so far. There is about 90 million reports on examinations or discharge reports. And my question is whether we can match these data based on social security numbers of the patients with other databases, whether there have been any plans made or whether it will be feasible at all technically. Well, this is not only a legislative problem, this is only a technical problem because, as I have mentioned, e-health should be a priority data source, and it is important to have access to those data to a certain width and depth. Certainly, they will not be matched based on social security numbers or birth numbers. We plan to use some specific technicality. I don't want to use it a pseudo identifier, but a kind of unified identifier. And we, in compliance with the law, we are competent to use statistical data. But in this case, we want, within the data hub and within our priorities on the NCZI, to have this unified identifier.
I understand, and since the time is almost up, I would like to ask the opinion and comment from the doctor. When you are in charge of the National Oncological Register, all we commented will probably our tasks, and this morning the Minister of Health at the meeting very resolutely said that he will set task and will require their fulfillment. Is it the correct step in your opinion? Can it be managed within the given or allocated time frame, and how you perceive the see the Czech approach? Thank you for that floor. I might start with what Martina said, the plans that are already there, which have been there for a longer period of time and which are being postponed in a way, we were considering in detail to move the data processing and to set a realistic objectives. The first one was to process 2013 and 2014, where the incidence year 2013 was already processed. Now we are finishing 2014, and from 2015 we should start in parallel with processing evaluation of this data also preparing the change of the information system when we will be working in a single information system and be able to process all years on an ongoing basis. It's linked to what Mr. Dušek said, that it shouldn't be done year after year to get to more current data, and what was said is one of the solutions that we will be able to process the years in parallel in at some quality. And if we use electronization and automation, we will find what is the situation working with paper forms at the same time, but being able to provide data for the years in some output at the quality we require. Okay, when I simplify it, probably the ranking in Onco registers will drop. That on the basis of that, we'll be able to make more correct decisions. I think this is very good because this is one of the big topics we were dealing with in the project, that we don't need to have everything perfect, but when we get it at the right time, it can have bigger impact. And since the time is up, I would like to thank our panelists with a round of applause. And also, this was the last point of our agenda. So, if unless Petra wants to say a couple of words in conclusion, no, she doesn't. So, I would like to thank all precious guests, participants, colleagues who work on this project, and I was very happy that you could be with us when we were signing the declaration and discussing things, and I believe that we will meet in a year's time regularly, and will be able to present some results, and the professor will still have his energy, and he will be helping us as he promised. So thank you again. Okay, the mic works. Super. If you permit me, I would like to hold you a little more, because this conference is a culmination, as it was mentioned, of a large project, which in fact will continue. In spite of that, Petra Zappe, our colleague, who had a couple of words in the introduction, deserves from me, from Ancem and the entire team, all of us, great recognition, because this conference at 3H had hard and all of this is thanks to Petra, because she managed to attract the Minister of Finance, not Minister of Finance, Minister of Health, maybe next time. Petra managed to get Minister of Health to a health conference. In the past, we had potential or would-be ministers. This time, it was truly a minister who is in his office and stayed with us 4 hours, which is a record, not only giving a speech and running after his duties. So a very big recognition, and also to all of you for staying with us. To our Czech colleagues and friends, thanks for coming from far, from Brno to us, to Bratislava. Martin, big thanks for great moderation, and Petra, thanks for another big, wonderful conference. Thank you. I thank you all, and especially my colleagues and the team, and all who are listening, all of you who were here. I firmly believe we will continue our cooperation and we will make it to other objectives, and I'm looking forward to working with you. Since we concluded, you are welcome to enjoy your lunch.